Dear colleagues, a warm welcome to the third OncoAlert Colloquium, this year being held in partnership with the American Society for Radiation Oncology, the European Cancer Organization, the European Society for Gynaecological Oncology, the European Oncology Nursing Society, the European School of Oncology, eCancer, the International Society for Geriatric Oncology, the Multinational Association of Supportive Care in Cancer, and the SWOG Cancer Research Network. Together, we bring you this end-of-the-year review of the Best of Oncology 2022, from trials to publications, drug approvals to current controversies within our field and future trends in treatment and research. This colloquium will last 6 days from January 23rd to January 28th, 2023. Links will appear on social media, and you can always find them via our website, OncoAlert360.com, and there you can find the colloquium webpage. You will find the possibility to subscribe to our newsletter, and we will send you the links daily. This colloquium is independent of any financial support and comes to you as a result of our partners and our faculty working hard in order to drive the field forward, regardless of geography. There is no sign-up, no information acquired or tracked. You simply click and watch. We truly hope that you enjoy this colloquium as much as we enjoyed making it. All the presenters have added their Twitter accounts at the bottom, and this was done in order to facilitate networking, contacting, and education. The days are separated by specific tumor groups, and our aim was to give you as much of a multidisciplinary approach as possible. Although we apologize to our surgery colleagues, we promise to have this included for our fourth colloquium. The daily links to the colloquium will be active at 12 noon EST, New York time, and 6 p.m. CET, Stockholm time. Once the presentation has been streamed for the day, it will be available to you on demand, and we highly encourage you and thank you for sharing it with all your colleagues at your institution to truly amplify the knowledge coming out of our faculty. Another way of receiving the links daily is always by signing up to our newsletter at www.oncoalert360.com. Today is day one of the colloquium, focusing on the best of breast cancer in 2022, and we're joined today by an amazing faculty, Dr. Erika Hamilton of Sarah Cannon Institute USA, presenting on advanced hormone receptor positive HER2 positive breast cancer. Dr. Hope Rugo of UCSF USA, presenting on advanced triple negative breast cancer. Ms. Janice Cowden USA, giving us the patient's perspective of this year in breast cancer. Dr. Evandro de Azambuja of Institut Jules Bordet, Belgium, presenting on early hormone receptor positive HER2 positive breast cancer. Dr. Myriam Lustberg of eCancer, presenting on early triple negative breast cancer. Dr. Icro Meattini of the University of Florence, Italy, presenting on breast cancer radiation oncology on the Astro session. Dr. Stephanie Graff of Brown University, USA, discussing current controversies and future trends in breast cancer research. Dr. Matteo Lambertini of the University of Genova, Italy, presenting on fertility preservation, and ending with a SWOG session by Dr. Cheung of the University of Nottingham, UK, presenting comparing surgery versus endocrine therapy in early operable breast cancer. Now, without further ado, Dr. Hamilton.
I'm Dr. Erika Hamilton, and I lead the breast cancer research program at Sarah Cannon Research Institute in Nashville, Tennessee. Happy to join you today on behalf of OncoAlert. I'm going to be discussing advanced hormone receptor positive as well as advanced HER2 positive breast cancer. These are my disclosures, and you'll note that all payment is to institution only for research purposes, no payment personally. So first, I'm going to go through HER2 positive breast cancer. We're going to briefly touch on hormone receptor positive in terms of HER2 low. I think this probably will also be covered in another presentation. And then we'll end with hormone receptor positive metastatic disease. So within HER2 positive metastatic breast cancer, we're going to be talking about DESTINY-Breast02 and DESTINY-Breast03. I think we're all quite familiar with trastuzumab deruxtecan at this point. It's an antibody drug conjugate with a DAR of 8 that has a quite strong bystander effect. This is DESTINY-Breast02. It was presented at San Antonio Breast Cancer Symposium in December of 2022. And this was the so-called third-line trial, really looking at trastuzumab deruxtecan versus treatment of physician's choice in second-line and beyond HER2-positive disease. You can see that at the time of this enrollment, all patients had already received TDM1, which was the standard treatment in the second-line setting, and patients were randomized to receive trastuzumab deruxtecan or capecitabine with either trastuzumab or lapatinib. You can see that about 3/4 of patients had prior pertuzumab, and about 40% of patients had endocrine therapy as they also had ER-positive disease. In terms of the endpoints, progression-free survival was improved by 10.9 months. That was highly statistically significant, and overall survival was actually improved by over a year at 13 months. The adverse event profile was quite consistent with prior trastuzumab deruxtecan studies, where nausea, vomiting, alopecia, and fatigue were the most common toxicities on trastuzumab deruxtecan. I think across the globe, we're now instituting an either 2 or 3 antiemetic prophylactic regimen for trastuzumab deruxtecan, as it is classified as a moderately emetogenic regimen. We also have to watch out for ILD pneumonitis, and across studies, this ranges somewhere between 10 to 15% for all grade ILD pneumonitis. Here you can see around 10.4%, and grade 5 or fatal cases only happened in 2 patients for 0.5%. What about DESTINY-Breast03? We also saw an update for this in late 2022. As we all know, this was our second-line trial that put trastuzumab deruxtecan head-to-head against TDM1 at the time. Progression-free survival was improved by 22 months with a hazard ratio of 0.33. And overall survival was our update at San Antonio Breast Cancer in 2022 and was also significantly lengthened. Although the median overall survival was not reached, the hazard ratio here was 0.64, and again, p-value of 0.0037. Also, I think important to note that of the patients that discontinued study drug, about 1/3 of them received TDM1 after TDXD, and about 17% actually received trastuzumab deruxtecan after TDM1, and yet we still saw quite a large magnitude of benefit of overall survival. What about adverse events in DESTINY-Breast03? We did see ILD pneumonitis. We saw this in about 15% of patients in any grade. The vast majority were grade 1 and grade 2. We only saw 0.8% grade 3 ILD pneumonitis, no grade 4, and no grade 5 events. Again, nausea is most prominent at about 70 to 80% of patients reporting some nausea, and we standardly use a 2 or 3 drug antiemetic regimen. I think it's also important just to remind our patients that alopecia is also quite common at about 40%, as this doesn't happen with some of the other antibody drug conjugates. So what about HER2 low metastatic breast cancer? And let's talk briefly about DESTINY-Breast04, as this was quite the news this year. So first, HER2 is really a continuum of expression in breast cancer. What we know up here in the top left of HER2 0, 1+ and 2+, and 3+. And really our low patients come from this category that is 1+ or 2+, and if 2+ also have to be FISH negative. In terms of the bottom right, how frequent is this? It's actually incredibly common in hormone receptor positive disease. You can see in blue, those are the rare 1/4 of patients that are HER2 0, but about half of patients have 2+ expression and another 1/4 have 1+ expression. So overall, about 75% of patients that are hormone receptor positive do have low HER2 expression. In terms of triple negative, we also see about 50% of patients that are HER2 low. More common to not have HER2 expression, about half of our patients, but then about 15 with 1+ expression and about 34% with 2+ expression. DESTINY-Breast04 was looking at trastuzumab deruxtecan in those patients with HER2 low expression. They had to have had 1 to 2 prior lines of chemotherapy in the metastatic setting. And if they were hormone receptor positive, they had to be considered hormone receptor refractory. So think about these patients as being patients that already went on to receive all the lines of endocrine therapy they were going to, and then had had 1 or 2 lines of chemo in the metastatic setting. They were randomized in a 2-to-1 fashion to either receive trastuzumab deruxtecan or treatment of physician's choice, which was single-agent chemotherapies, capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. Almost 2/3 of our patients had seen at least 3 prior regimens for metastatic breast cancer, and about 40% of patients had seen 2 prior lines of chemotherapy. In terms of our primary endpoint, in those patients that had hormone receptor positive disease, we saw a lengthening in progression-free survival from 5.4 months to 10.1 months for an absolute magnitude of benefit of 4.7 months. When we add all patients, so adding back in those triple negative patients, of which there were very small numbers on study, we really don't see this changing. In fact, the hazard ratio is now 0.5, and our absolute magnitude of benefit is 4.8 months. In terms of overall survival, we see an improvement of 6.4 months in our hormone receptor positive patients, moving the bar essentially from 1.5 years of overall survival to 2 years of overall survival. And in terms of all patients, when these triple negative patients were added back into the sample, we actually saw a magnitude of improvement of 6.6 months, really looking quite similar. In terms of adverse events, no surprises here. Again, nausea is still our most prominent symptom. You can see that neutropenia was less frequent with trastuzumab deruxtecan than single agent naked chemotherapies. And in terms of ILD pneumonitis with trastuzumab deruxtecan, we saw any grade in about 12% of patients, about 1% grade 3, and 3 patients or 0.8% with grade 5 fatal pneumonitis. So in summary, for patients that have HER2 low metastatic breast cancer, an improved progression-free survival of about 5 months, overall survival of over 6 months, and really no new safety signals. Trastuzumab deruxtecan was approved by the FDA for the treatment of metastatic breast cancer in the newly defined HER2 low subtype in August of 2022. And this really is quite remarkable, as only about 15 to 20% of our patients were HER2 positive and previously were eligible for this drug. And this really adds in an additional 50% of patients with metastatic breast cancer that potentially could derive benefit. A big conversation that we have to have at the local level is making sure that we capture the HER2 low expression in our clinic notes, make sure our pathologists know that an IHC of 1+ and 2+ is now actionable. And in those areas where only FISH is being done, we certainly need IHCs now. Let's move on to hormone receptor positive and HER2 negative disease. And you can see this is a relatively busy space. We have Tropics-02 here. We have novel endocrine agents. We also have Capitello with an AKT and some OS data from CDK4/6 trials. So this is Tropics-02. This was a phase 3 trial of sacituzumab govitecan versus treatment of physician's choice in patients that had metastatic breast cancer and were hormone receptor positive. I think this drug will also be covered in the triple negative metastatic section that somebody else is presenting. These patients had at least 1 endocrine therapy. They had to have received CDK4/6, and they'd had at least 2 lines of chemotherapy, but no more than 4 lines of chemotherapy for metastatic disease. So essentially 3rd to 5th line chemo. And they were randomized to either receive single agent chemo of CAPE, vinorelbine, gemcitabine, or eribulin, or sacituzumab govitecan given day 1 and 8 every 21 days. And what we saw was an improvement of progression-free survival of about 1.5 months, and this was statistically significant. And we saw an overall survival magnitude of difference at 3.2 months, a hazard ratio of 0.79, and the p-value was significant at 0.02. So let's move on to Emerald. This was our first large randomized oral SERD data. It was presented by Aditya Bardia, not this past San Antonio, but the year before. And patients that had progressed on 1 or 2 lines of endocrine therapy for advanced disease had to have had CDK4/6 inhibitor, were either randomized to standard single agent endocrine therapy, of which the majority got fulvestrant, or elacestrant, the oral SERD at 400 milligrams once daily. Prior fulvestrant was in about 30% of the population, and again, 100% had seen CDK4/6. So what we saw was an improvement in progression-free survival from 1.9 months to 2.8 months. And when we looked at those patients that had ESR1 mutation, this was enriched for a little bit larger benefit, 1.9 months up to 3.8. But I think all of us were a little bit underwhelmed with the magnitude of benefit, despite the fact that this was a positive study. We saw some updated data at San Antonio this past year, really looking at duration of prior CDK4/6 inhibitor in terms of how patients did on elacestrant versus other endocrine therapies. And what we see is specifically if we look at least 12 months or 18 months duration on prior CDK4/6, we really can enrich for a population that's deriving greater benefit from elacestrant. So if we look at least 18 months for all patients, elacestrant now approaching 5.5 months compared to really only about 3 months for endocrine therapy. And if we look at those patients that have ESR1 mutations for at least 12 months on CDK, or at least 18. Elacestrant is now giving us a progression-free survival of over 8.5 months compared to only 2 months with standard endocrine therapies. So in summary, this trial certainly did meet its primary endpoints in progression-free survival in all comers, as well as those that have ESR1 mutations. And the longer duration of prior CDK4/6 inhibitor, the longer PFS on elacestrant compared to standard of care. And I don't think this should really surprise us. It really would be quite atypical for our patient to have 6 months duration less than that on a CDK4/6 inhibitor in the first line setting. And so what we're probably doing here is really eliminating those patients that have endocrine resistant disease and getting a population that's more uniformly endocrine sensitive and thus going to get benefit from these endocrine therapies. So we also saw a negative data at ESMO in Europe this year for amcenestrant as well as giredestrant. We certainly can go into 1,000 reasons why maybe these trials were negative. They both were smaller. We did see a little bit increased activity again in those patients that have ESR1. We certainly can get into the dosing of these drugs. Certainly it can be hard to pick optimal doses for endocrine agents, but regardless, these studies were negative. We saw a second positive trial in terms of oral SERD at San Antonio this year, and this was the SERENA-2 trial with camizestrant. This trial randomized patients that had already progressed on at least one line of endocrine therapy to either fulvestrant or camizestrant at either the 75 milligram or 150 milligram dose. You can see that about 50% of patients had seen prior CDK4/6 inhibitor, and the majority of patients did have visceral disease. Progression-free survival was about 3.7 months in those patients with fulvestrant, and at both doses of camizestrant, progression-free survival was over 7 months. When we talk about those patients that have ESR1 mutations, median progression-free survival was 6.3 months and 9.2 months with camizestrant, and only 2.2 months with fulvestrant. So we now have 2 positive trials with oral SERDs. What side effects do we anticipate to see with oral SERDs? We don't tend to get as much arthralgias, et cetera, than we see with aromatase inhibitors. We can see some GI side effects, nausea and diarrhea. In my experience, this tends to be quite minimal and easy to manage. Some agents we can see some bradycardia. We certainly can see fatigue. We can see some changes in the peripheral vision with some of these compounds in changing light. So if somebody goes into the bathroom and flips their light switch on or off, this is a transient effect that goes away very quickly. And we can see hot flashes, but again, in my experience, this also compares quite favorably to aromatase inhibitors. So what about targeted agents for ER-positive disease? We also saw this data at San Antonio Breast of 2022, and this was Capitello 291, and it was a phase 3 trial with the AKT inhibitor capivasertib. Patients had it recurred while on or within 12 months of aromatase inhibitor. Prior CDK4/6 inhibitors were certainly allowed, and patients were randomized to either receive fulvestrant or fulvestrant with capivasertib. It turned out about 2/3 of patients had already seen CDK4/6 inhibitors, and prior chemotherapy was a little bit less than 20%. In terms of progression-free survival in the overall patient population, we saw significant lengthening in progression-free survival from 3.6 months with fulvestrant alone up to 7.2 months with capivasertib. And when we look at those patients specifically with AKT pathway alteration, so PI3, mTOR, AKT, 3.1 months versus 7.3. So the benefit here was really in all comers, not just those with PI3 AKT alteration. So capivasertib with fulvestrant is very likely to be an option for some patients following progression on endocrine therapy. overall survival data is certainly immature at this point. We've also seen some interesting data in terms of first line and the CDK4/6 inhibitors. You can see this table, PALOMA-2 with palbociclib, despite the fact that progression-free survival really looked identical across all of these studies, we're left now with palbociclib not having overall survival difference, where our 3 studies with ribociclib do. Our study with abemaciclib is not statistically significant yet, but we're seeing a hazard ratio that's 0.75. And again, this is the most immature trial in terms of when patients were enrolled. There still is another look at overall survival coming for these. Toxicity profile certainly can differ between these drugs, with palbociclib and ribociclib being a little bit more similar in terms of side effects, and abemaciclib being a little bit more unique with less neutropenia, but more GI toxicity in the form of diarrhea. So this may make some decisions depending on what side effect matches up best with the patient, their desires, and also their comorbidities. Thank you so much for your attention.
Hello, I'm Hope Rugo from the University of California, San Francisco's Comprehensive Cancer Center, and I'm pleased today to share with you the best of the year for advanced triple-negative breast cancer 2022 on behalf of the OncoAlert Colloquium. As you know, triple-negative disease is heterogeneous by intrinsic subtype, and now we understand that this heterogeneity in intrinsic subtype correlates to HER2 low or HER2 zero, one of, I think, the most important markers to arise out of 2022 in the treatment of metastatic breast cancer. As you can see, triple-negative cancers are largely basal-like based on intrinsic subtype, but 15% of these are either normal-like, HER2 enriched, or luminal. If you look at HER2 low, you can see that the most triple-negative cancers are going to be IHC 0, here 44%, about 15% are 1+, and in this series, about 10% were 2+. And we've seen a correlation with HER2 low status increasing hormone receptor positivity, as well as ERB2 copy numbers. We've made a lot of advances in therapeutic options this year, but we still have a lot of questions, and we'll talk about those more towards the end of this presentation. So where are we now with immunotherapy, and where are we going in the future? Can we amplify the immune response so that more than 38% of patients benefit from this treatment that improves survival? We've seen some interesting data with PARP inhibitors with combinations with immunotherapy. And then, of course, the drugs of the year are the antibody drug conjugates, sacituzumab govitecan, trastuzumab deruxtecan, and the newest kid on the block, which is still in phase 3 trials, datopotamab deruxtecan. So what's new in immunotherapy? Let's start with that area. Of course, we've discussed Keynote 355 before, but now it's published in the New England Journal, so I think it does count as an advance for 2022. In this trial, patients with metastatic triple-negative breast cancer, at least 6 months out from their treatment with curative intent in the first-line setting, were randomized 2-to-1 to receive pembrolizumab or placebo with a taxane or gemcitabine and carboplatin. Progression-free survival was significantly improved in patients who had PD-L1 positive disease, defined as a combined positive score of 10 or greater. That represented 38% of patients, and the absolute improvement in progression-free survival was 4.1 months, but more importantly, the hazard ratio is clinically significant and the p-value highly statistically significant. Overall survival was also improved in the most recent data to come out from this study, with an absolute 6.9-month increase in overall survival and improvements at landmark analyses. You can see that the overall survival benefit was also seen in patients whose PD-L1 by combined positive score was 10 or greater, and the p-value was 0.0093 with a hazard ratio of 0.73. We looked at PD-L1 CPS subgroups and the impact of differing expression of PD-L1 on overall survival and progression-free survival. What we saw was that PD-L1 of 10 or greater was the right cutoff. It didn't make any difference if you used 20 or greater, and then patients didn't seem to benefit from tumors that were PD-L1 less than 10. We've seen 2 other studies in the first-line setting for metastatic triple-negative breast cancer, although these aren't part of the best of this year. both studies with atezolizumab, the second study with paclitaxel showing absolutely no benefit in progression-free or overall survival, but a strikingly longer overall survival in the control arm than we've seen before in any trial. Impassion 130 did show a benefit in progression-free survival and overall survival in the PD-L1 positive population, defined differently than pembrolizumab. But the problem is that they had set up their statistical design so that overall survival could only be evaluated in the PD-L1 positive group if it was positive in the entire intent to treat group, and it wasn't. So for that reason, atezolizumab is no longer approved in the United States, although there are, of course, very important studies ongoing, and I think enough data to suggest that atezolizumab did probably improve survival here, but the statistical design was flawed. So what about PARP inhibitors? And I think this is really where we're going to get into the idea of expanding PARP inhibitors and what we can do potentially to improve the outcome with immunotherapy. So one idea, of course, is combining PARP inhibitors and immune checkpoint inhibitors, making cold tumors hot. We'll also talk about combining antibody drug conjugates with immune checkpoint inhibitors, another very exciting area to try and expand the use of immunotherapy and therefore the benefit for our patients. The idea behind this synergy between PARP inhibitors and immune checkpoint inhibitors really comes from the preclinical setting, where unrepaired DNA damage from PARP inhibitors leads to cytoplasmic DNA, which activates the STING pathway, which then again stimulates the host immune response by release of type 1 interferon and also infiltration of effector T cells. So a really great preclinical perspective. But what happens in the clinic? Well, we've seen some single arm studies already that have told us that you can combine a PARP inhibitor with immunotherapy safely. The DORA trial was a small trial. You can see there was only 45 patients evaluated in the intent to treat population in the table to your right. But patients were enrolled in the first or second line metastatic setting who received an induction chemotherapy and had at least stable or responding disease, and then were randomized to receive olaparib or olaparib with durvalumab, a checkpoint inhibitor. And the patient characteristics are listed here, but I think what's most important is that only one patient on the olaparib arm had a germline mutation in BRCA, and there were 7 patients in the olaparib and durvalumab arm, so not balanced for the small tumor trial population. Here you can see the data, and what's most important here, because this is a really tiny study, but it's hard to find these patients. And what they saw was that in all patients, there seemed to be a better PFS in the patients who got durvalumab, going from 5 to 6.1 months. But this was compared to a historical control because the trial was not designed and not powered to compare between arms. Patients who had still platinum sensitivity of their cancer did much better than those who had previous stable disease to prior platinum, which I think is fascinating. And then you can see that even if you look at the patients who are treated with a PARP inhibitor versus those who received the PARP inhibitor with durvalumab, that you're seeing responses across the map. And very interestingly, you're seeing responses in patients who don't have any mutation in this color-coded table to your right. Whereas patients who have the mutation, they didn't seem to benefit quite as much. So very important to understand this status and treat with PARP inhibitors early before you generate resistance with the use of more platinum salts. I think what's most striking about the DORA data in this tiny trial is that there are patients who were expected to respond to the PARP inhibitor and didn't, and yet there were relatively an equal number of patients who seemed to have clinical benefit who didn't have any predictive marker to either olaparib or olaparib and durvalumab. There are ongoing extensive correlative studies, including looking at methylation, which I think will be very important, and will give us a little bit of better idea about whether or not we can select a patient population to further study PARP inhibitors for one, and PARP inhibitors with checkpoint inhibitors. One important indicator that was seen were patients who had a prior response to platinum and hadn't progressed definitely had a longer progression-free survival and greater sensitivity to the PARP inhibitor. Overall survival is shown here, and again, compared to historical controls, it does appear that the overall survival is longer than we would have expected in this patient population. And in the olaparib and durvalumab arm, the progression-free survival was longer in patients with versus without a BRCA mutation, as you would expect, at 8.2 versus 2.9 months. So this is really just thought-provoking data. The most common adverse events were nausea, fatigue, and anemia, and adding the checkpoint inhibitor did increase a little bit of the sort of immune-related toxicities, but not many. And the majority of grade 3-4 adverse events were manageable without discontinuing therapy. 2 patients discontinued due to pneumonitis. So I think that this is interesting. You know, standard markers would not have selected the non-BRCA patients who benefited. We need to do more work on this. And there is an ongoing trial, phase 2 KeyLink 009 trial that looks at an induction with gemcitabine and carbo with pembro, and then randomizes patients after response or stable disease to olaparib and pembro or continued chemo and pembro. The issue about this trial was going to go on to be a phase 3, but patients were not selected based on CPS, and based on the really strong data from Keynote 355, the trial was completed at phase 2. We hope to see the data in 2023, and then potentially the trial will be reworked looking at patients who have CPS positive triple negative breast cancer. So now let's move on to antibody drug conjugates. I think, you know, without argument, the most exciting advance in chemotherapy for triple negative breast cancer and for overall breast cancer for hormone receptor positive disease that we've seen in a very long time. So sacituzumab is a first-in-class TROP2 directed ADC, and these results, of course, have been seen and published, but we saw additional data presented at ASCO with the final progression-free and overall survival in the brain metastasis negative population from the phase 3 ASCENT trial. So in this final analysis, we saw data that was quite similar to the initial data that was published in the New England Journal and led to FDA approval of sacituzumab govitecan in patients who've received at least one chemotherapy regimen for metastatic triple negative breast cancer. In ASCENT, 529 patients were randomized to receive sacituzumab govitecan or treatment of physician choice. Progression-free survival and overall survival were markedly improved in patients who received sacituzumab. And you can see that the curves for overall survival separate early, very early on, and stay separated over time. So this is a very important advance in the treatment of metastatic triple negative breast cancer. The toxicities from sacituzumab are important to understand and include neutropenia, diarrhea, alopecia, and fatigue. And the neutropenia is the most important at 63% grade 3 neutropenia and 59% all grade diarrhea, with around 8 to 9% having grade 3 diarrhea. Growth factors were used in about 50% of patients receiving sacituzumab govitecan. So the important lesson, I think, to take home is this is a very effective agent, and it improves progression-free and overall survival, but we really need to pay close attention to neutropenia. One strategy that we've been using more has been to use pegfilgrastim after day 8 sacituzumab and no growth factor after day 1 in patients who need growth factor support. And that's provided a very straightforward way to manage neutropenia quite effectively. I think another caution that's important is if a patient does get diarrhea, you need to treat the neutropenia, even if it's grade 3, because otherwise patients do run a risk of having edema of the bowel wall and potentially complications related to bacterial invasion of the bowel wall, so-called typhlitis. There are a number of studies that are evaluating sacituzumab govitecan now in the first-line setting. So ASCENT-03 in PD-L1 negative patients and ASCENT-04 in PD-L1 positive patients with metastatic triple negative breast cancer. Sacituzumab is given compared to treatment of physician choice in the PD-L1 negative population, and it's combined with pembrolizumab in the PD-L1 positive population, with this same idea that combining checkpoint inhibitors with antibody drug conjugates could be additive or synergistic. And the idea is here that antibody drug conjugates will actually cause exposure to neoantigens and enhance the host tumor response, the host tumor immune response, therefore allowing pembrolizumab to be more effective. There are also trials that are evaluating patients in the post-neoadjuvant setting, and there is a new trial which will look at sacituzumab and pembrolizumab versus pembrolizumab and chemotherapy of physician choice, capecitabine for most patients in the post-neoadjuvant setting. But in the metastatic setting, we're also looking at sacituzumab in hormone receptor positive disease in combination with pembrolizumab in a pilot study that has 2 arms, triple negative and hormone receptor positive disease in PD-L1 negative, triple negative breast cancer in the first-line setting out of Dana-Farber, a multi-site study, and then a new trial, an ASCENT-07 trial that will look at sacituzumab govitecan versus treatment of physician choice in hormone receptor positive metastatic breast cancer in the first-line setting. This is based on the data from TROPiCS-02, which showed in patients receiving a median of 3 lines of prior chemotherapy that sacituzumab improved progression-free and overall survival for hormone receptor positive disease compared to treatment of physician choice. A study, only really the second study, phase 3 study to show improvement in overall survivals and since the EMBRACE study. This is a trial which provides a effective treatment option in patients with heavily pretreated hormone receptor positive disease. So studying this in the first line setting, I think will be give us important information. So now T-DXd, which really I think has had incredible positive data, both in HER2 positive and HER2 low disease over the course of 2022. So T-DXd, as you know, is a novel antibody drug conjugate using trastuzumab biosimilar as a backbone and with a topoisomerase inhibitor payload. So how does this compare to sacituzumab govitecan as an ADC? Both drugs have high drug-to-antibody ratios, 7.5 to 1 for sacituzumab and 8 to 1 for T-DXd. They both have a topoisomerase payload, although the agents are different and may be non-cross-reactive. SN38, the active metabolite of irinotecan for sacituzumab, and deruxtecan, derivative for T-DXd. Both drugs are postulated to have a bystander effect, where the important factor is that the payload itself is membrane permeable, and after killing the tumor cell, even when the tumor cell is alive, can leak out of the cell once it's released from the linker and the antibody and kill neighboring tumor cells, which means that the agents may be effective even if the tumors do not express a high level of the target antigen. In fact, they may not need to express the target antigen at all. Sacituzumab govitecan in the ASCENT trial was shown to be effective across TROP2 expression, and the same is shown for sacituzumab govitecan in hormone receptor positive disease. So it makes sense that antibody drug conjugate like trastuzumab deruxtecan might be effective in patients who have very low expression of HER2 on their tumor cells. In a phase 1b study, T-DXd in patients who had HER2 low metastatic breast cancer resulted in a response rate of 37% and a median progression-free survival of 11 months, quite striking. So then we saw the results from the phase 3 DESTINY-Breast04 trial presented at ASCO to a standing ovation and published in the New England Journal of Medicine. In this trial, patients with centrally confirmed HER2 low hormone receptor positive breast cancer with a small exploratory subset of hormone receptor negative disease who had received at least 1 line, but not more than 2 lines of chemotherapy for metastatic disease and at least 1 line of endocrine therapy were randomized 2 to 1 to receive T-DXd or a menu of chemotherapy agents. The trial was powered to look at progression-free survival in the hormone receptor positive subset. However, 58 patients were enrolled who had hormone receptor negative, classically known as triple negative disease, that was HER2 low based on central testing, 1+ or 2+ without gene amplification. In terms of the patient population, for triple-negative disease, which is the focus of my talk, what's important to understand is that most of the patients had visceral disease, and the median number of lines of chemotherapy in the metastatic setting was 1. Here you can see the data in the exploratory analysis in hormone receptor negative HER2 low disease, where the improvement in progression-free survival was 5.6 months and improvement in overall survival was almost 10 months. Really remarkable data in this small population. Only 40 patients were treated with T-DXd and 18 with treatment of physician choice. So we do need confirmatory data, but the FDA felt based on this data that they could approve T-DXd in patients with at least 1 line of prior chemotherapy for metastatic disease who had HER2 low status by immunohistochemistry, regardless of hormone receptor status. Toxicity, of course, is important to understand. Nausea is the most common toxicity from T-DXd and does require prophylaxis as well as management after infusion, but generally can be managed well and is not a reason for significant discontinuation, although it did result in dose reductions in about 4.5% of the patients. Interestingly, cytopenias are really not seen very much with T-DXd, so that's a very good thing in terms of managing our patients, that we're not really worrying about neutropenia, anemia, or use of growth factors. Diarrhea is seen in a small number of patients and is generally low grade. The most important toxicity in terms of serious adverse events is interstitial lung disease or pneumonitis, which was seen in 12% and was fatal in 0.8% or 3 patients. What's really important in terms of managing interstitial lung disease in patients receiving T-DXd is to hold the drug in patients who have grade 1 ground glass opacities that's asymptomatic, treat with low-dose steroids, and then you can restart treatment when patients clear the ground glass opacities, but you have to stop completely in patients who have symptomatic, at least grade 2 ILD. And this is a good way to avoid mortality from this drug, which I think we saw in the HER2 positive setting can be completely avoided. So T-DXd has also been studied in combination with the checkpoint inhibitor durvalumab in patients who had HER2 low metastatic triple-negative breast cancer in the first-line setting. 58 patients were treated with a median follow-up of just over a year, and some of the patients had de novo triple-negative disease, a little more than a quarter of the patients. What we saw was a remarkable response rate of 57% in this 58-patient group, updated at San Antonio this year in 2022, and a median progression-free survival of slightly more than a year. It didn't make any difference, in fact, whether patients had PD-L1 positive disease, and that's shown in the waterfall plot, and the responses were very durable, shown in this spaghetti plot in the lower right-hand corner. As you can see, the majority of patients had very good disease control, with some patients progressing right after the first dose or right after the first 2 or 3 doses. So it's important to keep in mind that it's not universal, but the results are very encouraging. In terms of HER2 status by local testing, there was no real difference on response based on patients who had IHC 1+ or 2+ without gene amplification. And I think the numbers are too small to really draw any conclusions out of this. Now, I mentioned the third kid on the block. This is datopotamab deruxtecan, a TROP2 antibody drug conjugate with deruxtecan as the payload. This is an interesting ADC because it has a lower drug to antibody ratio of 4, but it seems to be very potent, potentially because it delivers the deruxtecan very effectively. It also has this bystander effect and has been tested in the Tropion Pan-Tumor-01 study, where patients who had received a median of 3 prior regimens for advanced disease, and about a third had received prior topo-1 inhibitor-based ADC, were treated with single-agent datopotamab deruxtecan. The response rate overall was 32%, and if you looked at the subset of patients who hadn't had a topo-1 inhibitor, it was 44%, with a median duration of response that was quite impressive at 16.8 months in these pre-treated patients with triple-negative disease, unselected for HER2 low status. Median progression-free survival was 4.4 months overall, and 7.3 months for those who had not seen a prior topo-1 ADC. Median overall survival is also impressive in this patient population, and they do have unique toxicities with datopotamab deruxtecan, with stomatitis seen in 73%, and pretty much all patients who stay on the drug long enough will get stomatitis, and the grade 3 rate was about 10%. Nausea is also seen with vomiting, and alopecia in about a third of the patients, with 14% grade 2, meaning complete alopecia. We found in our I-SPY2 neoadjuvant trial that using a steroid mouthwash is very effective at reducing the stomatitis and in preventing it. So we're using this prophylactically as a standard treatment now for patients who are receiving Dato-DXd as neoadjuvant therapy in the I-SPY2 trial. We have an ongoing trial with datopotamab deruxtecan compared to chemotherapy of physician choice as first-line treatment in 600 patients with metastatic triple-negative breast cancer that's PD-L1 negative, or there's also a caveat that if you're living in a country where you don't have access to checkpoint inhibitors, you could also enroll if you have PD-L1 positive disease. The 600 patients will be randomized 1-to-1 with dual primary endpoints of progression-free survival and overall survival, and this trial is actively accruing. Datopotamab deruxtecan has been studied in combination with durvalumab in the Begonia trial in patients who had prior treatment for who did not have prior treatment for metastatic disease, so in the first-line setting. Again, the response rate was quite remarkable and even higher than what we saw with TDXD in the first-line HER2 low triple-negative population. This is an unselected first-line triple-negative population with a response rate of 74% and very durable responses as shown in the spaghetti plot. In addition, it didn't make any difference whether you had PD-L1 low or high tumor. And stomatitis was seen. This was before we started using the prophylactic steroid mouthwash that we use with everolimus. Diarrhea and, of course, nausea is an ongoing side effect that can be managed effectively with prophylaxis and rescue medication. One toxicity that's worth mentioning is dry eye and rash. So these are datopotamab toxicities, but generally very self-limited and easy to manage. ILD was seen in this trial because of durvalumab. Dato-DXd has not been associated with interstitial lung disease. So I'll leave you with a roadmap for treating metastatic triple-negative breast cancer that has changed a little bit since we did this best of the year after San Antonio 2021. We are still differentiating treatment when patients are diagnosed with metastatic triple-negative breast cancer based on PD-L1 status in the United States using the combined positive score, and in countries where atezolizumab is available, also using SP142 of 1% or greater, depending on the intended checkpoint inhibitor. Patients who are PD-L1, whose tumors are PD-L1 positive, receive pembrolizumab and nab-paclitaxel if they don't have taxane resistance, or paclitaxel, and they can receive gemcitabine and carboplatin if they have more resistance evidence to taxanes. I don't use a PARP inhibitor up front, even if a patient has a germline BRCA mutation, because we've seen survival benefit with pembrolizumab, and we haven't seen that with PARP inhibitors in 2 phase 3 trials. But I think one interesting area to explore is the approach used in the DORA trial, adding the PARP inhibitor to the checkpoint inhibitor as maintenance therapy. If that's not available, the PARP inhibitor can be the second-line treatment after progression of disease. In patients who have PD-L1 negative disease, we would use chemotherapy as first-line treatment or a PARP inhibitor if they have a germline BRCA mutation. And then we've been looking at PARP inhibitors in patients with somatic BRCA mutations as well as patients with PALB2 mutations, and that's another area of active exploration. In the second-line setting, an antibody-drug conjugate is the indicated treatment, as we've seen improvements in survival, again, our gold standard. Sacituzumab govitecan has a level 1 evidence from a large phase 3 trial, so I would generally use sacituzumab govitecan preferentially. Of course, clinical trials are important, looking at combinations with immunotherapy that I would definitely look to if they were available to you. And then novel antibody drug conjugates, TDXD in triple-negative HER2 low disease, chemotherapy, and in patients who have high tumor mutation burden, checkpoint inhibitors are all options for a sequential therapy, and understanding the benefit of sequential antibody drug conjugates is of critical importance, and a number of registry as well as prospective trials are planned to open this year. With that, I'll thank you very much for your attention and thank OncoAlert for putting together this Best of the Year program. Thank you.
Hi, my name is Janice Cowden, and I'm a metastatic breast cancer patient advocate. I'm pleased to be invited by the OncoAlert team to share my perspective on what went right in 2022, what is still missing, what we can do better, and what advocates are excited about in the pipeline. These are my opinions based solely on what I've learned as a patient advocate with a focus on research and science and input from other patient advocates. So we'll start with what went right in 2022. The most exciting discovery that benefits patients across all subtypes of metastatic breast cancer is the development of antibody-drug conjugates. 2022 was certainly a blockbuster year for ADCs, expanding beyond HER2-positive MBC. Most noteworthy for me was the phase 3 DESTINY-Breast04 trial results presented at ASCO 2022 by Dr. Cheung Modi. There was a doubling of progression-free survival and overall survival, which is amazing, even more so for those with metastatic triple-negative breast cancer. And this was my first time attending ASCO in person, and it was such a privilege to be in that room filled with so much energy, excitement, and emotion during that standing ovation. I've attended many scientific breast cancer conferences over the past 6 years, but this was a first. It's a moment in time I'll never forget. Within months, we saw FDA approval of Enhertu for estrogen positive and triple negative metastatic breast cancer with HER2 low expression. Other developments were moving forward towards personalized medicine with discoveries of new biomarkers and development of targeted therapies. We're also gradually seeing a shifting of the old MTD paradigm, with experts calling into question the old thinking that the highest dose of oncology drugs is always the most effective dose, especially with newer targeted therapies. In fact, Dr. Hope Rugo presented a session at San Antonio last month titled RIP MTD. In this session, Dr. Rugo highlighted the work of the PCDI, Patient-Centered Dosing Initiative, which is a patient-founded and led organization focused on advocating for better quality of life for people living with MBC through patient-centered dosing. PCDI surveyed oncologists in 2021 in the US, and 85% of the respondents stated that they did not believe that the higher dose of a cancer drug is always more effective than a lower dose. And 97% of the respondents said that they would be willing to discuss flexible dosing options with their patients. This survey led to the publication of a paper in Breast Cancer Research and Treatment in October 2022. For more information and survey results, please visit therightdose.org. Also, the FDA has launched 2 initiatives, Project Optimus, which focuses on dose optimization and dose selection in oncology, with the goal of maximizing efficacy as well as safety and tolerability of a drug, not simply finding the maximum tolerated dose. To encourage investigators to evaluate a range of doses in clinical trials. And Project Renewal, with the goal of looking at older oncology drugs and evaluating scientific evidence to determine if label updates are needed. This led the FDA to announce a label change for capecitabine in late 2022 to include several dosage regimens and an option for a lower starting dose for patients with MBC. Another thing done right in 2022 was a focus on inclusion of patient advocates in all aspects of research, clinical trial design, drug development, as key stakeholders in efforts to improve care and outcome for all patients with cancer. 2 publications that stood out to me in 2022 were The Rise of the Expert Patient in Cancer from Backseat Passenger to Co-Navigator, where patients are described as e-patients, equipped, enabled, empowered, and engaged, also as experts in their experience of living with cancer, and valued for their ability to move oncology forward as leaders in science communication. This was published in JCO Oncology. And the manuscript Improving the Odds Together, a framework for breast cancer research scientists to include patient advocates in their research. This was published in Nature with first author, Dr. Hilary Stiers. We also saw many breast cancer patient advocates included in sessions at major cancer conferences in 2022. At ASCO last June, we heard Stephanie Walker, NBC patient advocate, present on the big stage results of the Become Research Project, which aims to better represent Black people in cancer research by increasing access to clinical trials for NBC. And at San Antonio last month, we saw Christine Hodgson, who is an NBC patient advocate and co-founder of Graff, along with Stephanie Walker, as co-presenters in a session on living with metastatic breast cancer. So what's missing and what can we do better? We need better predictive and prognostic tools. For example, there's a clear need for a more accurate tool to detect HER2 low expression in order to determine patients who will benefit from HER2 low directed therapies. Metastatic triple-negative breast cancer remains a challenge with a poor prognosis and survival rates that have not improved enough over the past decade. We need a better focus on quality of life, access to palliative care, and improved management of treatment-related side effects. For drugs like Enhertu, which is effective for many patients, it's not an easy drug due to the side effects. We have more work to do understanding mechanisms of resistance and how to predict which patients will benefit from treatment drugs. Another challenge is sequencing of new targeted therapies, especially those in the same drug class like ADCs and CDK4/6 inhibitors. Head-to-head comparisons of drugs in the same class like the CDK4/6 inhibitors would be helpful. Clinical trial participation is still far too low. For all patients, but especially those in diverse and underserved communities. Decentralization of clinical trials could improve access for patients who would not otherwise be able to participate. There are still disparities in healthcare that need to be addressed, and financial toxicity is problematic for many with metastatic breast cancer. Patients shouldn't have to suffer financial ruin or choose between putting food on the table and paying for treatment. Although we saw major cancer conferences, including patient advocates in presentations in 2022, we can still do a better job of including the patient voice at smaller and community oncology conferences. Not all conferences include a patient advocate registration category, and access to conferences for patient advocates could be improved through scholarships and discounted registration fees. After all, we are the end users and the beneficiaries of breast cancer research. So include us and learn from us. As we often say, nothing about us without us. So what are patients most excited about in the pipeline? At San Antonio last month, we heard about two promising oral SERD clinical trials, SERENA-2 with camizestrant and EMERALD with elacestrant, and several other exciting endocrine therapies in the pipeline. I would have to say that oral SERDs top that list. And for patients who qualify for these oral SERDs, it will improve their quality of life. They will no longer have to go to the clinic every month to get 2 painful injections. There's so much more that deserves to be said here, but in the interest of time, I will close by saying thank you for your time and attention, and thank you to the OncoAlert team for inviting me here today.
Hello, this is Dr. Myriam Lustberg presenting on early stage triple negative breast cancer. As you all know, triple negative breast cancer has worse outcomes compared to other subtypes of breast cancer with higher relapse rates and higher likelihood of distant disease progression. Triple negative recurrence peaks within the first 3 years after treatment, and mean time to distant recurrence is approximately 2.4 years for triple negative breast cancer compared to 4.4 years for hormone receptor positive breast cancer. Most deaths, unfortunately, occur in the first 3 to 5 years of diagnosis. As you can see, we absolutely continue to need to search and develop better therapies for this most aggressive subtype of breast cancer. Although we talk about triple negative breast cancer as one entity, TNBC is composed of multiple subtypes. As you can see here, the majority tend to be the basal cell-like in orange. However, there's the immunomodulatory immune-enriched subtype, the luminal androgen receptor subtype, and the mesenchymal subtype. And there's ongoing research in terms of further developing better targeted therapies that could be personalized to each subtype of triple negative breast cancer. Where are we in terms of targeting triple negative breast cancer? Certainly we have identified these various targets, and it's clear through multiple research studies that many patients do have an aberration in at least one of these pathways, and there's ongoing work in terms of how we can better target these pathways as a way of improving outcomes in triple negative breast cancer. However, till we have better validated biomarkers and better targeted therapies that are geared toward these pathways, we are essentially using traditional chemotherapy regimens. Generally, T1A tumors are not receiving chemotherapy. T1B tumors, I think it's a discussion with patients based on their goals, other medical comorbidities, age, and other factors. And generally, anybody with T1C tumors or greater is absolutely being treated with chemotherapy as long as they're fit. And it's very much recommended that we consider the neoadjuvant approach for these larger tumors so that we could have that the data for complete pathologic response. And we'll talk about some of those options later in the talk. In terms of what type of regimen we're choosing, generally lower risk tumors, we're trying to use a non-anthracycline regimen. So this applies more to T1B tumors. With T1C tumors, I think depending on age and other characteristics, it's a pros and cons discussion about whether to use a third generation regimen or not. And then as we saw from the ABC trials, really when you look at node negative T2 tumors or node positive disease, there's an absolute improvement, as you can see here, favoring an anthracycline third generation regimen. So let's talk a little bit about the neoadjuvant approach. We know that the addition of carboplatin has been shown in multiple studies to improve complete pathologic response. As you can see here, these all favor the additional platinum therapy. I'll highlight one recent study that has had longer term follow-up, and that was the Brightness study, which looked at the long-term efficacy and safety of the addition of carboplatin to the traditional chemotherapy backbone with or without the PARP inhibitor olaparib. In this study, as with other studies, what was shown was that there was improved event-free survival with the addition of carboplatin. There was no difference with the additional PARP inhibitor, and the study was not really powered to look at overall survival advantage signal. So again, consistent event-free survival benefit that's seen across studies with the addition of carboplatin. And until San Antonio this year, we used to consistently say that we did not have a study that actually showed an overall survival advantage with the additional carboplatin until the TMC neoadjuvant platinum study was reported in San Antonio this year. This study was conducted in India with over 700 patients, essentially looking at the addition of platinum therapy versus not to traditional third generation anthracycline taxane based regimen. And as with other studies, the significantly improved event-free survival was seen, as you can see on the left, with improved 5-year event-free survival favoring the platinum group at 70% compared to 64% in the control group. Most importantly, there was for the first time an overall survival advantage being reported with 5-year survival at 74% in the platinum group compared to 66% in the control group. So for the first time, we have overall survival confirmation with the additional platinum therapy in a phase 3 study. So to summarize our findings about carboplatin, it absolutely increases path CR rates. It improves breast conserving surgery rates. It does indeed increase toxicity rates when added to anthracycline taxane regimens. Event-free survival is improved across multiple studies, and for the first time, we have an overall survival signal seen in the phase 3 study, TMC. Looking at the role of immunotherapy in early stage breast cancer, we know that chemotherapy leads to tumor lysis and increased antigen shedding and increased PD-L1 expression. And multiple studies have shown synergy between checkpoint inhibitors and chemotherapy in the neoadjuvant setting. A few of these studies, including Keynote 173 and I2 studies, are shown on the right here. So all of these data were the basis of further developing the prospective definitive Keynote 522 study, which I will show in the next slides. So Keynote 522 enrolled patients with newly diagnosed triple-negative breast cancer who either had node-positive disease or had at least a T2 tumor size if they were node-negative. And patients were randomized 2-to-1 to a standard backbone of chemotherapy with anthracycline plus carbo and paclitaxel, and the intervention arm received pembrolizumab in the neoadjuvant phase in combination with both carbopaclitaxel as well as with doxorubicin and cyclophosphamide. Then patient proceeded to have surgery, and no matter what the results were, the non-intervention placebo arm continued receiving placebo, whereas the arm that had received pembrolizumab continued adjuvant treatment with pembrolizumab for another 9 cycles. The results of the study showed that across all planned interim analysis, there was significant improvement in pathologic complete response rates with the last interim analysis showing that 63% of patients were able to achieve a complete pathologic response compared to 56% of those patients not receiving pembrolizumab. And most importantly, PD-L1 was not predictive of benefit to the additional pembrolizumab, whether tumors were PD-L positive or not. In the neoadjuvant setting, all tumor types, regardless of PD-L1 status, benefited from receiving the immunotherapy containing regimen. Here we're looking at event-free survival by nodal status, and as you can see, certainly patients, whether they were node positive or node negative, continued to benefit from the addition of pembrolizumab, and as expected, patients who were node positive and did not receive pembrolizumab had actually the worst outcomes in terms of event-free survival. Treatment-related adverse events are listed here, and as you can see, pretty much the vast majority of patients are experiencing some type of toxicity during treatment, whether they receive pembro or not. Grade 3 to 5 toxicities were comparable between the two groups, although more patients did have to discontinue treatment in the pembrolizumab arm. In terms of treatment-related adverse events in the adjuvant phase, similarly, close to half the patients continue to have experienced toxicities in the adjuvant phase, Grade 3 to 5 toxicities tend to be more common in the pembro-containing arm, and there were serious complications in 3.2% of the pembro-containing arm, and 4.3% had to discontinue therapy in the pembro arm. So, as I mentioned, the Keynote 522, really the design was such that adjuvant pembro continued whether PCR was achieved or not. And there are ongoing questions of whether this is indeed needed, particularly for patients who actually achieve a complete pathologic response. And this is an area of active debate. And Keynote 522 was not the trial that's going to answer that question, so additional studies are needed. I do want to highlight the Jafar-Quattro study that is pointed out here, where in this study conducted by the German breast group, the design was a bit different in that immunotherapy was not continued post-surgery. And in looking at kind of the disease-free survival curves as well as overall survival curves, you can see that the results are quite strong and good with this approach. So essentially, these are additional studies that need to be further validated in terms of the utility of adjuvant immunotherapy, especially for patients who have had a complete pathologic response. So what happens if patients did not achieve a complete pathologic response? This was also another limitation of the Keynote 522 regimen, in that whether they did or did not, the standard approach of adding capecitabine based on the CREATE-X study, which you see the schema here, was not included in that study. And the CREATE-X study really has set the standard, which is that especially for patients with triple-negative breast cancer who do have residual disease, 8 cycles of adjuvant capecitabine significantly improve disease-free survival. Do you want to highlight the dismal rates that we're seeing here, which is that even for patients taking 8 cycles of capecitabine, this would be without immunotherapy, 5-year disease-free survival is at 70%. So clearly we need better options for patients with residual disease, and we'll talk about some of the upcoming clinical trials in this space. However, in terms of the actual benefit of capecitabine, multiple studies have confirmed beyond CREATE-X that there is an overall survival benefit in the use of this adjuvant treatment in triple-negative breast cancer. And for this reason, even though it was not included as part of the Keynote 522 adjuvant backbone, it is highly recommended that we do include this for patients with residual disease as they receive their adjuvant pembrolizumab. But clearly, we need better options. The ECOG Akron EA1131 study, which randomized patients with triple-negative breast cancer to capecitabine versus platinum, again suggested that when we have these extremely aggressive basal types of triple-negative breast cancer, whether we use platinum, whether we use capecitabine, disease-free survival tends to be less than half. So clearly we need better options for improving outcomes for patients who have not been able to benefit fully from preoperative chemotherapy. But what about patients who do have a targetable pathway? And the Olympia study was really a hallmark study that showed with patients with germline BRCA1 or 2 mutation, if they were triple negative and did not have a complete pathologic response, or if they were in the adjuvant group with triple negative breast cancer with either T2 or N1 disease, essentially these patients were randomized to receive 1 year of the PARP inhibitor olaparib versus placebo, and the primary endpoint was invasive disease-free survival. And the results, as you can see here, highly favored the use of olaparib, with the difference in invasive disease for survival being 8%, favoring the use of olaparib. Most recently, we are also seeing overall survival advantage emerging, really highlighting the importance of using this targeted therapy for patients with germline BRCA1 and 2 alterations who meet Olympia criteria. A year of additional adjuvant therapy, certainly the concern would be additional toxicity, and in terms of quality of life indices that were measured during the study, there was no significant difference between olaparib and placebo. And a subsequent reporting of fatigue rates showed that even though there was a numeric higher rating of fatigue, the actual difference in terms of being clinically significant was not there. So it's possible for patients to receive a year of olaparib and not have worsening of quality of life features. So to summarize our current status of early stage triple negative breast cancer, certainly for moderate or high risk early stage triple negative breast cancer, the recommendation would be to follow the Keynote 522 regimen with a anthracycline plus a platinum containing taxane regimen in combination with pembrolizumab, going to surgery, and if patients do not achieve a complete pathologic response, capecitabine for 6 to 8 cycles is recommended. For patients with germline BRCA mutations, olaparib for those who do not achieve a complete response, and then still continuing pembrolizumab. There are actually data in the metastatic setting that pembrolizumab can be safely combined with both capecitabine and olaparib. So I think in this setting, we wouldn't do all 3. Obviously, patients with germline mutations would receive olaparib plus pembrolizumab, and patients with non-germline mutations would receive capecitabine from pembrolizumab. So this is one conception that is actively being practiced right now by various breast-specific clinicians throughout the world. Kind of looking at a roadmap, this is a slide courtesy of Rugo, really kind of synthesizing some of the themes we talked about, which is that, you know, with the T1C tumor, I think some discussion needs to be had in terms of whether to do neoadjuvant chemo or not. I think this is a case-by-case discussion. And kind of consideration of a platinum-containing regimen for these T1C tumors versus a traditional anthracycline taxane regimen. And then for those tumors that are node positive or T2 or greater, really the regimen would be kind of similar to the Keynote 522 regimen. Patients go to surgery, and as I mentioned before, if they do not have a pathologic complete response, really the path is determined by whether they have a germline BRCA mutation or not. With those that do have a mutation receiving olaparib, those with wild type receiving capecitabine. Those that receive PCR, I think that the current standard is to complete 1 year per pembrolizumab, but really ongoing studies are evaluating whether the possibility is that no further therapy may be needed in that setting. So what are some up and coming studies to address unmet needs in triple negative breast cancer? As we talked about, both capecitabine in the adjuvant setting as well as platinum were shown to be quite dismal in terms of improving outcomes in basal type triple negative tumors. So the question is whether sacituzumab as a TROP2 antibody drug conjugate could do better compared to treatment of physician choice. So this is the SASHIA study. And there are ongoing adjuvant studies looking at there's the SWOG 1418, looking at a phase 3 study of pembrolizumab for residual TNBC, where patients are randomized to pembrolizumab versus observation. And also the phase 3 adjuvant avelumab versus observation for triple negative breast cancer. So the question of kind of how do we look at the adjuvant use of immunotherapy in high-risk disease. The optimized PCR study is looking specifically at patients who achieve a complete pathologic response, and they are randomized to pembrolizumab for 27 weeks versus observation. And this trial will be led by Alliance Foundation with PI Sarah Cheung. And then the question is, what if we can further use our targeted therapies, such as our PARP inhibitors, to maybe spare chemotherapy with patients with baseline germline alterations? And the study led by Jennifer Leighton showed that just using single agent neoadjuvant PARP inhibitor, talazoparib, really had PCR rates of 53%, which is very much close to what we're seeing with chemotherapy, immunotherapy rates. And so the TBCRC 056 study led by Erika Hamilton is looking at the combination of PARP inhibitor niraparib in combination with immunotherapy. And 2 of the arms are for triple negative breast cancer, and this is an exciting study to really use our targeted therapy for patients with germline BRCA alterations in combination with immunotherapy. Do want to take a few minutes to highlight an exciting emerging area of actually using liquid biopsies, circulating tumor DNA across various areas of the disease spectrum. And this has been studied most in triple negative breast cancer, but it's being looked at in all subtypes of breast cancer. But essentially, can we use circulating tumor DNA both for diagnosis, treatment monitoring, detection of minimal residual disease, and detection of resistance? And so multiple studies have shown that when patients have minimal residual disease detected by circulating tumor DNA, they do have worse outcomes. What we do with this information is something that has not been worked out, which is if we're able to intervene when patients where we are detecting minimal residual disease, how do we intervene? And if we do intervene, are we able to change outcomes? So these are subject to additional studies that are needed, and this will be needed before we can actually implement these assays in routine clinical use. But I just wanted to highlight just one of these studies looking at triple negative breast cancer. This was the OxCell study that was presented in 2021 San Antonio Breast Conference, essentially taking patients with triple negative breast cancer who did not have a complete pathologic response, and they had monitoring for ctDNA as they went on to receive additional interventions, including immunotherapy, capecitabine or gemcitabine plus immunotherapy. And what we see is that the ctDNA is absolutely, detection is associated with worse outcomes, and it's often found quite early. So the opportunity to intervene can be quite narrow in these patients, but definitely additionally confirming the finding of ctDNA minimal residual disease as a negative prognostic marker. How we use it as a predictive biomarker needs to be further determined. We'll wrap up by saying that we have talked a lot about different subtypes of triple negative breast cancer, and I do want to at least briefly mention that some of the triple negative, what we call triple negative breast cancers, may have a HER2 low signal characterized by 1+ or 2+, but FISH negative. Yes, the IEC signal is subject to a lot of observer variability, and we're still looking into how to most reliably test what is HER2 low versus not. However, I think as we look at the subset of triple negative breast cancer that even with this imperfect assay are kind of falling into that HER2 low category, it's a third of the triple negative breast cancer. So I think this poses an opportunity in future studies to really look at additional HER2 antibody drug conjugate therapy, which has been shown to have activity in the metastatic triple negative HER2 low setting, but poses additional opportunities in the early stage setting in the future. So with that, I thank you and appreciate OncoAlert inviting me to give this talk.
Hi, my name is Evandro de Azambuja, a medical oncologist from the Jules Bordet Institute in Brussels, Belgium, and it's my pleasure to be here in this OncoAlert Colloquium to discuss with you the data that was presented in San Antonio 2022 about early breast cancer, and I'm gonna focus in triple positive, meaning hormone receptor positive, HER2 positive breast cancer. These are my disclosures. This is the agenda for today's meeting. We're gonna give you some introduction, then we're gonna discuss whether the hormone receptor positive HER2 positive is a different entity. I'm gonna give you some updates from San Antonio 2022 and some discussion, take-home message and conclusions. If you start with hormone receptor positive, this encompasses about 70% of all breast cancer. But if you talk particularly in hormone receptor positive HER2 positive, this is only about 10% of the patients. And whether this is a different entity, I can show you with this figure. This on the left side is Pizza's figures. They do represent the data from Alex Pratt using PAM50. If you see the left inside, hormone receptor positive HER2 positive, you can see that they are over 65%, they are enriched with luminal A and B, 30% are HER2 enriched. And if you look on the opposite, the other figure, hormone receptor positive, HER2 positive, the vast majority, 3/4, 75% are HER2 enriched, and less than 10% are luminal. So there is a big difference in this. Also, this review here, this figure on the the right-hand side, sorry, done by my colleague Mariana Brandão, looking particularly for HER2 positive, ER positive. You can see they are ER dependent. They have low HER2 EGFR pathway activation. They have a high rate of PI3K mutation. They have low proliferation rate in P53 mutations, and they have low TILs and immune activation. So this is a different entity. They do respond different to treatments. This figure looks for trials that were treated patients with neoadjuvant chemotherapy and anti-HER2 drugs, in this case, a dual blockade with trastuzumab pertuzumab, or single blockade with trastuzumab and chemo, in Neosphere, Trifiena, and the NeoAuto with trastuzumab lapatinib. As you can see from this figure, the pink bars represent the hormone receptor positive, the blue bars represent the hormone receptor negative. As you can see, pathological complete response is much higher for ER negative HER2 positive compared to hormone receptor positive HER2 positive. The data from the HERA trials, adjuvant trial of trastuzumab with chemotherapy, you can see the final results at 12 years shows that the overall survival is similar between hormone receptor positive and HER2 positive and hormone receptor negative HER2 positive. So they are about 81, 78, 79%. That is not a big difference. We see a slight difference at the beginning of the trial at 5 years because the hormone receptor positives, they tend to relapse later. But at the long-term follow-up, there is no difference. Again, with the dual blockade with pertuzumab, trastuzumab in affinity trial, you look according to hormone receptors positive or negative, and you can see that both derive benefit from the addition of pertuzumab to trastuzumab in chemotherapy. So we have a very good outcome for those patients. If you look in data in the metastatic setting, in this case, The Cleopatra trial looked for hormone receptor status, positive versus negative. Patients were treated with pertuzumab, trastuzumab, and taxane, and you can clearly see that independent of the hormone receptor status, the benefit is present for the dual blockade in terms of progression-free survival or overall survival. So let's go through some updates in the San Antonio 2022 for the triple positive early breast cancer. So the first trial that I'd like to show is the APT trial that was conducted by Dr. Sarah Tolonay. It's a phase 2 single-arm trial that really changed the landscape of treatment of our patients. So patients with hormone ER positive or ER negative, HER2 positive, they were node negative. 49% had T1A or T1B tumors, 42% T1C, only less than 10% had T2 tumors less than 3 centimeters, and 67% were hormone receptor positive. These patients received paclitaxel trastuzumab weekly and then completely 1 year of trastuzumab adjuvant. So as you can see, the final results at 10 years presented now in San Antonio shows very nice outcomes in terms of invasive disease-free survival, 91.3%. And if you look in terms of hormone receptor positive, they have a similar good outcome, 90%, 91%. In terms of relapse-free survival, again, very good results at 10 years, 96%. And if you look in terms of hormone receptor positive and negative, both 96%. So again, show you that this escalated treatment works in patients with HER2 positive early breast cancer and small tumors, and there is no difference according to hormone receptor status. They looked a little bit further. They tested the HER2 score, HER2-DX score, that is a score that takes into account ER, the subtypes, the proliferation, some immune signatures, the tumor size, and node status. And here they used a cutoff of 50 for testing, and they could see that those patients that they had almost 5% of the patients, the tumors they had HER2-DX high, and it was different according to the subtypes, with a vast majority, 71% of HER2 and less 50% in the luminals. There was no association between HER2-DX score and HER2 status, but what they looked first, they looked with the cutoff of 50. There was no difference at the long term at 10 years if they were high or low, but when you use an optimal cutoff of 32, you can see a separation of the curves between high and low. So this shows that that is promising that maybe you can use this test to de-escalate treatment, but this needs to be prospectively validated. The second trial, presented by Dr. Tarantino, the attempted trial, the 5 years results, is a phase 2 randomized trial. Patients were randomized 3:1 to TDM1 or paclitaxel trastuzumab. There was no intention of comparison in the trial. What they found that 5 years invasive disease-free survival and relapse-free survival was very good with TDM1 alone, 97%, 98%. They also looked into the invasive disease-free survival according to the hormone receptor status. The 5-year invasive disease-free survival is similar if they are hormone receptor positive or hormone receptor negative, 97% in both treatment arms. Another thing that they also did the HER2-DX in this trial. Here they use a cutoff of 50. They didn't use the optimal cutoff of 32, but even with the 50 cutoff, they could already see a difference in terms if a patient had a HER2-DX high or low. So a better outcome for patients with HER2-DX low. Another trial at a long term as well, the CLGB 4601. This trial, just to remember, 400 patients, HER2 positive early stage breast cancer, stage 2 and 3. Patients were treated neoadjuvantly with paclitaxel, trastuzumab, or lapatinib, or the combination of both for 16 weeks. Then they went to surgery. They recommended dose dense AC and completed 1 year of trastuzumab. Here they tested the mutations, PI3CK mutations, and you can see that 17% of the patients had this mutation. They look in the mutation according to the hormone receptors, positive or negative. The negative 15% had a mutation, the hormone receptor positive 20% mutation. And if you look at the outcome according to the hormone receptor status and the PI3K mutation, you can see that patients with hormone receptor positive and mutated have a worse outcome compared to the others. And you can see in this multivariable Cox model equally. Those patients with a PI3K mutation, hormone receptor positive, they have a worse outcome. Another trial, the FEONIT trial, was a trial looking for a neoadjuvant treatment with dual blockade pertuzumab, trastuzumab, docetaxel, or docetaxel trastuzumab. Patient went to surgery, received the FEC, and then completed dual blockade or single blockade. This trial is restricted to patients of Asia population. The event-free survival was very good, confirming that dual blockade improved the outcome at 5 years in terms of event-free survival, disease-free survival, and there is a benefit in terms of overall survival, a difference of 6%. So here, unfortunately, they did not show data according to hormone receptor status, but we assume that the benefit should be equally distributed in both, perhaps not at 5 years, but perhaps a longer term of follow-up. And then an interesting trial was the TRAIN-3 trial, looking for patients to test whether you can use image to drive our decision when to stop treatment. So patients with HER2 positive breast cancer, 0.5% of them, they were hormone receptor positive, 232, half hormone receptor negative, 235. Patients received 3 cycles of paclitaxel, pertuzumab, trastuzumab. They would have an imaging MRI if they had complete response radiologically, they would go directly to surgery. If not, they would receive 3 additional cycles, another imaging evaluation. If he responds to surgery, if not, MRI. They completed the chemotherapy up to 9 cycles, then surgery. PCR completed pertuzumab, trastuzumab, no PCR, they would go for TDM1. What was interesting to see that the cumulative pathologic complete response first, if you look in patients receive up to 9 cycles of treatment, 80% of hormone receptor negative had pathologic complete response compared to only 43%. So half of the patients have a pathologic complete response if they are hormone receptor positive compared to the hormone receptor negative. And this is the same for patients who receive 1 to 3 cycles, up to 6 cycles, or up to 9 cycles, again, showing that they do respond different to neoadjuvant treatment. And if you look in terms of radiologic complete response, similar, you can see that patients with 1 to 9 cycles, if they were hormone receptor positive, they had up to 9% of certainty of have PCR, compared to 89% of patient hormone receptors negative. So we can conclude that the 3 cycles of pertuzumab, trastuzumab, paclitaxel can be an early predictor of PCR in 1 out of 3 hormone receptor positive, but only 1 out of 6 hormone receptor positive. And then you can identify the complete response by imaging. You can identify pathologic complete response with 88% sensitivity hormone receptor negative and less than 60% hormone receptor positive disease. What is the future? For triple positive early breast cancer, there is the Flamingo study, very interesting study, looking for HER2 new peptide, GLSI 100 in patients with residual disease or high-risk pathologic complete response. During the treatment of trastuzumab-based, the patients are screened for HLA type. If they have HLA-A02 positive, the patients are randomized to receive GLSS 100 or placebo. And if they do not have the mutation, they continue just in follow-up. And what they do here, they do for the first 6 months, 1 monthly injection to try to prime the immunization of those patients. And then after 6 months, they do a booster for 5 more times. So they try to increase the immunological response of our patients. And these include both hormone receptor positive and hormone receptor negative tumors. So what are the take-home messages? HER2 positive disease. the bar is very high. It's difficult to improve much further the outcomes of those patients, which is very good news for the patients. So how can you conclude this? HER2 positive disease is showing excellent long-term outcomes. De-escalation strategy tested in terms with long-term follow-up, like the APT trial at 10-year confirming reassuring survival data. The triple positive breast cancer, it is a different entity in terms of prognosis, relapse risk, and response to treatments. Besides the use of hormone receptor status, some molecular characteristics could be used to further refine treatment in the future, including the HER2-DX, but this should be further validated. Despite that we have, that they have different biologies for hormone receptor positive, hormone receptor negative, HER2 positive early breast cancer, they are still treated similarly except for endocrine therapy. You really need to consider in clinical trials, targeting separate these two entities. And there are new promising treatment options under evaluation, could change the standard treatment indications in the next future. With this, I would like to thank you for your attention. I'd like to thank my research fellow, Elisa Agostineto, who helped me with this presentation. Thank you very much.
Hi, my name is Dr. Stephanie Graff, and on behalf of OncoAlert, I'm honored to be presenting today the emerging trends and current controversies guiding research in breast cancer. I am the Director of Breast Oncology at the Legarreta Cancer Center at Brown University, and I have a broad agenda today covering numerous different trends that I'm going to dive right in. This is Kandinsky's composition 10, and I think it's a lovely piece that helps us consider the question guiding hormone receptor positive breast cancer right now, which is, how do we fit all of these different shapes and colors and pieces of targeted therapy in the hormone receptor positive space together in the best shape and sequence to help patients stay on non-cytotoxic therapy in the most patient-centered manner for the longest. Starting with the SERD and SERM landscape, of course, there are numerous drugs in development. Amnestrant and Giredestrant have released press statements saying that they had early negative data. Ongoing research continues with lasofoxifene, imlunestrant, elacestrant, and camizestrant. So much more to come in the SERD and SERM landscape. Cross-trial comparison between these four compounds as they continue is impossible as cross-trial comparison goes. Very different in terms of phase of development, numbers of patients available for analysis, prior fulvestrant exposure, prior CDK4/6 inhibitor exposure, and also the number of patients in the studies with evidence of ESR1 mutations. As we consider those things, though, it really helps inform the way that we think about the hormone receptor positive endocrine therapy landscape and how these different populations can be very heterogeneous and how that might change subtly the responses that we're seeing in trials and how we consider these response rates. So starting to think about defining endocrine resistance, we saw at San Antonio Breast in 2022, Dr. Bardia presented data from the elacestrant trials looking at the definition of endocrine resistant using duration of CDK4/6 inhibitor, which is an unusual definition we haven't used much in the past, where patients who had been treated with a CDK4/6 inhibitor for 12 months or longer did better on elacestrant than those who had had a shorter duration of CDK4/6 inhibitor therapy. That benefit did seem to persist in those who had evidence of a mutant ESR1. This gives us one potential strategy to select patients or identify patients who might benefit from this switch therapy or the SERD-SERM landscape. Previously, of course, we've also seen the PADA-1 trial, which used biomarkers to select and consider endocrine resistance. In PADA-1, serial blood analysis for detection of ESR1 was used and drove an early switch therapy to fulvestrant compared to a more traditional definition of disease progression. And we saw with that molecularly defined endocrine resistance and disease progression that we saw an improvement in progression-free survival with the early switch from an aromatase inhibitor to fulvestrant. This is despite the fact that data that we also saw at San Antonio Breast in 2022 from Geriatric et al., that fulvestrant isn't the optimal drug for patients with ESR1 mutations. We've seen that the pharmacodynamics across the various point mutations with ESR1 are highly variable, and that the emerging SERDs and SERMs on the landscape have different drug affinity based on which mutation is present. This creates the possibility that we might get very specific in which drug we prescribe for which mutation as these agents continue to develop and emerge. Next question in this composition we're creating is, are all CDK4/6 inhibitors the same? Of course, we've had this question for a while. Early on, we saw progression-free survival hazard ratios that were very similar across the palbociclib, ribociclib, and abemaciclib landscape. But now that the overall survival data is starting to mature, we've seen that the Paloma-1 and Paloma-2 data using palbociclib was not statistically significant, but that the Mona Lisa data using ribociclib has shown statistically significant improvement in overall survival with hazard ratios of about 0.7. And although the Monarch 3 data is not yet statistically mature, the hazard ratio is similar to what we've seen in the Mona Lisa data, giving at least me some hope that as that data matures, it may turn similarly positive, but only time will tell. This just continues to linger in the backbone. And so as we think about that, I offered you Claude Monet's paintings of the Rouen Cathedral in different seasons under different light, and ask, can things be both different and the same? And I think the answer is, of course, yes, which is complicated. Perhaps we all have different preferences for which CDK4/6 inhibitor we think is best based on the data and the phase 3 randomized trial results. But of course, they all have different adverse events and they all have different financial toxicities for our patients. And so we may need to have a second choice or a third choice in order to mitigate those particular side effects for a particular patient that's with us in that moment. Of course, in a culture of global scarcity, there's also an opportunity to figure out how to use these 3 agents to promote better drug access for a globe of patients diagnosed with metastatic breast cancer, to promote access to treatment for more people diagnosed with the disease. Next is, can we extend CDK4/6 inhibitors beyond progression? We have seen both Dr. Kalinsky present the MAINTAIN trial and Dr. Mayer present the PACE trial. They are fundamentally different trials. MAINTAIN was largely a switch trial where most of the patients had previously had palbociclib and were switched to ribociclib. The PACE trial was a continuation trial where all the patients had had prior palbociclib and were continued on palbociclib in the second line. And we saw different results where MAINTAIN had a statistically significant improvement in progression-free survival and PACE did not. And so questions persist on whether or not CDK4/6 inhibitors will have a role beyond progression. And the post-Monarch study is accruing and ongoing. It is a phase 3 randomized trial asking whether beyond progression on any first-line metastatic hormone receptor positive CDK4/6 inhibitor, if changing or continuing abemaciclib plus fulvestrant will improve progression-free survival, and we await those results. I encourage you all to consider referring your patients for that trial. As another question in the hormone receptor positive landscape is really trying to figure out what the mechanism of resistance to CDK4/6 inhibitors is so that we can better select patients and consider, again, how to sequence these drugs. Cristina Garaducci presented data at San Antonio Breast in 2022, looking at how pre-existing subclones really emerge as a result of treatment, both with palbociclib and abemaciclib, and that stochastic events really lead to the development of resistant alterations during treatment with abemaciclib. And that while palbociclib cells retain sensitivity to abemaciclib, abemaciclib cells do not seem to retain sensitivity to palbociclib. This all really helps inform how we think about resistance to CDK4/6 inhibitors and can help shape our thinking as we continue to ask those questions about CDK4/6 inhibitor beyond progression. Another question is, how then do we overcome that resistance? We've already seen early evidence that AKT inhibitors like capivasertib may be effective at overcoming resistance, and that other emerging agents like CDK2 inhibitors, TTF inhibitors, and aurora kinase inhibitors may be emerging compounds on the market for that. As any photographer will tell you here, Harry Callahan's photograph multiple exposure tree, exposure matters. So as we evaluate and analyze the trials that are ongoing, the data that is emerging, the question will be, how are we considering endocrine resistance? The length of time that patients have been on endocrine therapy, the line of endocrine therapy exposure, whether it was in the adjuvant or the metastatic setting, the exposure and length of time that somebody was on a CDK4/6 inhibitor and which specific CDK4/6 inhibitor that patient took, whether or not a patient has an ESR1 mutation and which specific ESR1 mutation is present, and how that patient is monitored in terms of things like ctDNA analysis for early detection of those changes, using blood-based biomarkers and versus conventional definitions of disease progression. We can all imagine a future where a patient with high-risk early-stage breast cancer is treated with something like monarchE. Of course, we're still waiting on NATALEE, followed with an aromatase inhibitor or endocrine therapy, followed by a longer duration of endocrine therapy. Perhaps they have serial biomarker testing for evidence of molecular recurrence or endocrine resistance. And at the time that that develops, they undergo switch therapy, targeting the development of that mutant ESR1 with the SERD or SERM that best matches their pharmacodynamics. Maybe that's paired with a CDK4/6 inhibitor, and then they're monitored for evidence of clonal expansion that could drive resistance to the CDK4/6 inhibitor. Maybe at that tipping point, the CDK4/6 inhibitor is changed. Maybe when CDK4/6 inhibitor resistance starts to emerge, a new agent is introduced that can help restore CDK4/6 inhibitor resistance, like an AKT inhibitor or a PIK3CA drug, ultimately prolonging the duration that our patients are on oral-based, non-cytotoxic therapy with these molecularly targeted agents that hopefully improve their patient-centered care, oral-based therapy, and patient flexibility in care. Moving to premenopausal breast cancer, which of course has a very different face, very different characteristics of disease than hormone receptor positive breast cancer, we continue to analyze and consider the implications of the results of the TAILOR-X and the RxPONDER trial. Questions that remain in our research paradigm are, is chemotherapy just really toxic ovarian function suppression? What is the additive value or toxicity of ovarian function suppression to chemotherapy? Is there a population of lymph node positive patients who can safely omit chemotherapy? Or is there an ultra low population who can ultimately omit even endocrine therapy, especially in the lymph node negative population? And ultimately, in a premenopausal patient, given their factors like depression, physical or social well-being, how can we optimize adherence, which we really know is a barrier? Finally, given the premenopausal demographics of disease and the preponderance of triple-negative breast cancer in a premenopausal population, it is important that we continue to consider the impact of checkpoint inhibitors on fertility. Early data has shown us that checkpoint inhibitors likely contribute to immune cell-mediated infertility, and we do not yet know how that will affect patients long-term, and whether some of the interventions that we have available to us at this time to help shield patients from that toxicity, like GnRH agonists, would be effective, and how best we can support patients through side effects like this. And so considering this as a toxicity, counseling patients and supporting patients is an important research question in the future. This moves us over to triple-negative breast cancer. Here is Jackson Pollock's The Key, which he painted in 1946 and was considered really an evolutionary piece of work that showed spontaneous actions and chance effect. And I think is a nice piece to talk about triple-negative breast cancer. In triple-negative breast cancer, one of our really questions that lingers is that backbone of the KEYNOTE-522 regimen and whether it's exactly right. Here, Georgia O'Keeffe's flying backbone. Should the anthracyclines be dose dense? We know from earlier work that dose dense chemotherapy improves overall survival. Of course, in KEYNOTE-522, the anthracyclines were administered on a 21-day cycle. And so we don't know how increasing the density of the anthracycline delivery would change efficacy of KEYNOTE-522 versus toxicity of KEYNOTE-522. Do we need the anthracyclines at all? Dr. Sharma has presented the results of our NeoPact trial, which looked at carboplatin, docetaxel, and pembrolizumab on a 21-day cycle, saw a wonderful 58% pathologic complete response rate and a great 2-year event-free survival amongst those who had a pathologic complete response, suggesting that there's a clear population of patients that could have anthracyclines omitted. And ultimately, do we even need the immune checkpoint inhibitors? 51% of patients in the placebo arm still had a pathologic complete response. And of those in the placebo arm who had a there was an 85% event-free survival, which says that there's some patients that don't benefit from the addition of the pembrolizumab. So how could we better select patients? If PD-L1 is not the right choice, what is? Could we use TILs? Is there another biomarker? This will be an important research question to help us determine what the right backbone is for the KEYNOTE-522 regimen in the next couple of years. Moving to the adjuvant side of triple-negative breast cancer, what about that adjuvant pembrolizumab that continues? Obviously, we saw for patients that had a pathologic complete response that the event-free survival was wonderful, regardless of whether they were in the pembrolizumab or the placebo arm. And for those that did not have a pathologic complete response, unfortunately, there was still a high risk of recurrence, even with the pembrolizumab. And so what's the right thing for either group of patients? For those who had a pathologic complete response, comparatively in both NeoPact and Jepar-Nuevo, there was no adjuvant immune checkpoint inhibitor, and we saw great, again, 2-year data. And so an ongoing trial question is the optimized trial, which is randomizing patients after pathologic complete response to pembrolizumab versus observation alone. In patients who did not have a pathologic complete response, of course, right now we do have the option of adding capecitabine, or for those who have a BRCA1 or BRCA2 pathogenic variant of agent like olaparib. And we have clear data that these agents are beneficial. However, all of that data is from a pre-KEYNOTE-522 world. So it's difficult to counsel patients because we don't know the magnitude of benefit after a 4-drug chemotherapy plus immune checkpoint inhibitor, what the benefit of capecitabine or the benefit of PARP inhibition will be, and trying to get that data so that we can better sit with patients in that space and informed decision-making is important. While I do not think that that data will ever be collected in phase 3 randomized designs at this point, I do think that it is an area that is ripe for real-world analysis, and I look forward to seeing that. Of course, it's an ADC world, so ongoing in patients with residual disease after KEYNOTE-522, or in this case, hormone receptor positive disease as well. There is the SASIA study, which is randomizing patients to sacituzumab govitecan versus treatment of physician's choice. This will ask whether antibody-drug conjugates have a role here. Similarly, in partnership with SWOG's clinical trial partnership, TROPION-Breast03 is randomizing patients after KEYNOTE-522 to either datopotamab deruxtecan plus durvalumab versus datopotamab deruxtecan alone, or investigator's choice chemotherapy. Datopotamab deruxtecan, Dato-DXd, is a antibody-drug conjugate that targets TROP2. and has the same chemotherapy payload, deruxtecan, as we've seen with trastuzumab deruxtecan. And so we look forward to seeing how that antibody drug conjugate performs in this post neoadjuvant chemo KEYNOTE 522 with residual disease space as well. This, leaves us with this landscape majestic for patients with early stage triple negative breast cancer. And we're still trying to put the collage of how best to fit this together. Again, we can imagine the future where patients are better selected based on clinical, pathologic, and molecular features for an anthracycline or anthracycline sparing immune checkpoint inhibitor or not, dose density or not, and then based on whether or not they have residual disease or not, go on to receive appropriate therapy. In the case of a pathologic complete response, maybe observation alone. In the case of residual disease, maybe olaparib, maybe capecitabine, maybe an antibody drug conjugate or an immune checkpoint inhibitor, maybe some combination thereof. And I look forward to seeing this landscape mature here by Nicolene Thomas. In HER2 positive disease, it is the great shuffle here, a game of cribbage. So the shuffle is, obviously in a patient with high risk HER2 positive disease. Classically, we're giving neoadjuvant TCHP, followed by Catherine for patients who don't have a pathologic complete response, sequencing first line, second line, third line, fourth line, and beyond therapy. And now we're really mixing it up. So the question is, can drugs like trastuzumab deruxtecan or tecotinib outperform Cleopatra in the first line metastatic setting, or Catherine in the non-pathologic complete response setting? Or could they even be used in combination? Could tecotinib plus TDM1 be better? Could trastuzumab deruxtecan and tecotinib be used together? And importantly, as these drugs move earlier and earlier, what are we going to be offering in the future for third and fourth line therapy, second or third or fourth line therapy? And so we look to those phase 1 trials, new agents in the HER2 positive space, new drugs to be emerging. To really round out our 360 vantage point of the emerging trends, I think other things going on that are important to discuss in the breast cancer landscape are that we continue to ask questions about how we can best design and conduct and accrue culturally diverse clinical trials, how we can mitigate financial toxicity for the patients that we care for, how we can eliminate boundaries to care for patients both locally and globally to get more care for more patients efficiently, safely, and with the highest quality, how we can advance partnerships with patients and patient advocates in our clinical trial work and our daily work, how we can improve workplace culture for the oncology workforce as a whole and for our trainees, importantly, and then how we can best incorporate supportive care, biomarkers, imaging, AI to improve quality and safety and really oncology care all around. Thank you so much for your time on behalf of OncoAlert, and I hope you enjoyed this review of some emerging trends and controversies guiding research. Thanks.
I'm Jo Taylor, and I've been living with metastatic breast cancer for 9 years on first-line treatment. I was diagnosed with early stage breast cancer 15 years ago in 2007. I was on maternity leave with my daughter, who was 5 months old, and son, who was nearly 2.5 years old, and that was hard enough. 7 years later, I developed metastatic breast cancer. By this time, I already knew Beth Caldwell in America, who was advocating for change, and other advocates from BCSM, breast cancer social media, Twitter chats. I was aware of metastatic disease, but found that many early stage patients are not aware. And over the years, I've highlighted that there's a huge lack of awareness in the UK, which is why I created After Breast Cancer Diagnosis, as well as the charity METUP UK, based on the American METUP organisation that Beth and Jenny Grimes founded. One of the things that I created was 2 infographics, one for ductal breast cancer and one for lobular breast cancer, to support awareness of metastatic breast cancer patients for early stage awareness of metastatic breast cancer for early stage patients. This is now signposted by NHS England, and the infographics are used in Greater Manchester Cancer with an end of treatment summary report for early stage breast cancer patients. I have HER2 positive disease, so from conferences I do look at my own specific disease type, but I'm always interested in what is happening in other disease types due to the Met Up UK charity that I founded and the wide range of breast cancer patients, advocates that have different disease types. I like to share up-to-date research and information with patients. I was lucky enough to attend ESMO 2022 in Paris, and it was quite overwhelming after 2 years of no conference, the huge amount of people that were there. I took the time to connect with more advocates and also asked many questions. I think at each session I stood up at the microphone and asked at least one question from some of the presentations. It was a great experience attending in Paris and meeting the other advocates again. Advocates are needed to speak up and help to make change in many areas of the metastatic pathway, and like myself need to be seen and given a platform for a voice. I think one of the things that would be good is some kind of buddying system in conferences. I met a new friend from Ireland who was able to help and share and guide in some of the sessions at ESMO. Maybe it needs to be thought about at other conferences as well. Some patients really are too intimidated to attend, so it would be a great way of helping them and guiding them at research conferences. We need advocates involved in the early stage of trial design, and that was something that was highlighted. One of the things that I noted that there were reports that there's a lack of diversity in clinical trials, especially for Black and Asian patients, and that is a huge problem. Thankfully, the light is being shone on the issue now, and therefore hoping that there will be change with more inclusion, as we cannot continue to ignore the lack of diversity. There was a focus on supporting patients with brain metastases with specific drugs, and brain mets patients finally being included in trials. One problem that we have in the UK is that there is no stratified pathway for having a brain MRI. Brain mets are therefore usually diagnosed with a symptomatic scan, and we need to be supporting those metastatic breast cancer patients who are high risk with HER2 positive and triple negative breast cancer. Being symptomatic when treated is really not helping us with better outcomes for survival. HER2 low was the big news in all the conferences. The drug Enhertu already used in America for low HER2, but currently not approved in the UK for low HER2. But it can be beneficial for many patients, even with very low HER2 expression. I listened to Kelly Shanahan mention that if you had a biopsy originally and there was even a small bit of HER2, then it can open up Enhertu as a treatment option. Another point for patients with ER positive disease is the use of CDK4/6, as there were reports of the 3 CDK inhibitor drugs as to which are the best to choose, and seem to be favouring abemaciclib, but in some cases it's not necessarily the best option, but at least there is a choice. Some patients have slow-growing breast cancer and may benefit from trying different drugs in the same class, like the CDK4/6 drugs. A very UK problem is red tape blocking access to drugs, as there are rigid protocols with treatment lines. It also seems to be a problem in Canada. Triple negative breast cancer is still a huge unmet need. Even with Trodelvy, this subset of patients need more options. I've seen the devastation with patient advocates with this disease, and the urgency cannot be ignored. I'm interested in oligometastatic disease, and I had oligomets in my sternum, which was surgically removed and replaced. One piece of research talked about zapping any disease with focal radiation as well as systematic treatment, but whether that has a significant impact on survival wasn't always clear. But I know from my own experience, I've been living 9 years on first-line treatment. Therefore, I really do feel that there are benefits of treating certain patients in this way dependent on their disease type. Genomics is the key to opening up better treatments for our disease, and we desperately need genomics in standard of care. Again, something highlighted at these conferences. This is where you make a difference for patients getting better targeted treatments and possibly opening up possibilities of clinical trials for patients. Patients are learning that the reason that their treatment isn't working, that the cancer mutates. Sometimes it isn't just one drug that needs to be used, and we need to be smarter to support those patients who have these issues. ctDNA or blood biopsies are progressing with efficacy. We need these tests to be able to be used in the area of metastatic progression so that it can be found earlier, treated earlier, and therefore hopefully have a better outcome and better quality of life because the cancer can be managed better. We want to know why metastatic breast cancer is only categorised by receptor status when it's well established that it's much more complex than that. In the UK and across the world, patients living with metastatic breast cancer need to be counted. We need data, and this is something that I've been striving for over the last 9 years. Data saves lives, and having the information on the number living with metastatic breast cancer will support us better living with the disease, better research, better clinical trials. To finish off, I'd like to comment that we all need support with side effects, and we need oncologists to understand that we will also seek out second opinions. We need the right supportive care. We may need support in knowing what holistic therapies there are available, what additional treatments there are. Some patients in the UK will pay for other therapies if they know that there is an option. Giving people the information and let them decide. We need guidance in supportive or complementary therapies and knowing what we can and cannot use. If you don't discuss this with patients, then you may get problems with contraindications. Patients really need to be aware of any issues that they could have, detriment to the effect of their treatment that they're on. We need openness and honesty instead of the problem that patients don't tell the doctor because they don't feel they can or they feel that they're being judged. Again, this can be detrimental to their treatment. Therefore, please have these open discussions. Finally, we need to drive change together, and we all need to work together so that patients get the best support. Thank you, OncoAlert, for giving me the opportunity to talk about my perspective in 2022.
I'm Icro Meattini, University of Florence, Italy. First of all, I would like to thank OncoAlert for this invitation to have this colloquium 2022, this year in radiation therapy in breast cancer, best of 2022. These are my disclosure information, nothing related to this presentation. And this is the agenda of this 2022 layout with some from consensus statements, preoperative radiation therapy and postoperative radiation therapy after neoadjuvant systemic therapy, regional node irradiation internal mammary node, something from ductal carcinoma in situ of the breast, and more from 2022. We start this year with an important document from the European Society for Radiotherapy and Oncology Advisory Committee and on patient selection and dose fractionation for external beam radiation therapy in early breast cancer. This was a project to support equity of access for all patients to optimal evidence-based breast external beam radiation therapy in order to identify open questions to guide future research. The project was based in several steps and modified delivery strategy. We identified 23 panelists selected by the ESTRO ACROP committee and the ESTRO National Societies Committee that review critically existing literature on whole breast, chest wall nodal, and partial breast irradiation. These are the main consensus statements on whole breast irradiation and nodal irradiation, where moderate hypofractionated should be offered regardless of age at breast cancer diagnosis, pathological tumor stage, breast cancer biology, final surgical margin status, tumor bed boost, breast size, the presence of the invasive or pre-invasive ductal carcinoma in situ, oncoplastic breast conserving surgery, and the use of systemic therapy. Concerning ultra-hypofractionation, 26 grain 5 fraction as per fast-forward trial for breast irradiation can be offered as standard of care or within a randomized controlled trial or prospective registration cohort, depending on the country. And concerning nodal irradiation, there was a consensus on moderate hypofractionation as standard of care for nodal irradiation, while ultra-hypofractionation should not be offered for nodal irradiation until ongoing trial results are fully reported. Concerning chest wall irradiation, there was a strong consensus in favor of the use of moderate hypofractionation for chest wall irradiation of the breast reconstruction, and for chest wall irradiation even regardless of time and type of breast reconstruction. Partial breast irradiation selection criteria, the main trials have been revised, and these are the consensus statements on patient selection for external beam radiotherapy. Here in these slides are summarized luminal-like subtype small tumors, size less than 3 centimeters, the absence of lymph-vascular space invasion, non-lobular invasive carcinoma histology, tumor grade 1 and 2, low to intermediate grade ductal carcinoma in situ of the breast, size less than 25 millimeters with clear surgical margins equal or more than 3 millimeters for patients aged 50 years old or more, with unicentric unifocal lesion and clear surgical margins in case of the invasive case more than 2 millimeters. Not negative status, including isolated tumor cells, and no use of primary systemic therapy or neoadjuvant chemotherapy. Concerning regimens and dose fractionation, partial breast irradiation, moderate HNS per import low and Danish trial 40 grain 15 fractions, and ultra-hypofractionation between 26 and 30 grain 5 fractions represent acceptable schedule for external beam breast irradiation, while twice a day external beam partial breast irradiation dose and fractionation, similar to those used in the RAPID and IRMA trials, should not be offered, concerning some concerns in terms of toxicity. So in conclusion, hypofractionation demonstrated to be safe and effective in all the analyzed scenarios, and a consensus to offer it as standard of care was fully reached by the expert consensus panel. Of course, some barriers still exist and should be further developed, something like lack of experience with new fractionation, lack of resources in some specific context, the need to review reimbursement policies in some countries, considering the treatment as a whole and complexity as a whole, instead of just number of fractions, and some logistic barriers. Of course, this consensus tried to accelerate implementations and further development of the evidence-based radiation therapy in clinical practice worldwide, in order to identify and to stimulate the scientific community to overcome these existing barriers, to show where further evidence is still needed. Concerning precision medicine, let's start from preoperative radiation therapy. At the University of Florence, have been published last year and then presented at San Antonio Breast Cancer Symposium 2022 the results of the ROC trial. The ROC trial was a phase 2 trial of preoperative radiation therapy that aimed to treat these patients with robotic radiosurgery to evaluate acute toxicity, disease control, and cosmetics. Basically, we treated patients aged 50 years and older, affected by invasive early hormone receptor positive HER2 positive HER2 negative breast cancer with lesion size 2 centimeters and a half, suitable for breast conserving surgery with non-negative unifocal with lesion at least 5 millimeters from the skin. They were treated between diagnosis and surgery with a single fraction preoperative radiosurgery of 21 gray. These are the main results in terms of acute toxicity, where you can see how no toxicity greater than grade 2 was observed, and no postoperative complications related to the surgery was observed. Concerning cosmetics, still some concerns in terms of those exist. At 12 months, 10% of patients reported a poor cosmetic outcome, but more than 76% of patients reported good to excellent cosmetic outcome. At 18 months, still around 10% of patients reported a poor cosmetic outcome. Some questions about treatment efficacy. We observe a 10% of patients with pathological complete response. Please take in account the few days between and surgery. Unfortunately, it's really important the imaging in the staging preoperative, since we reported 30% of patients with postoperative positive nodal status and final surgical margins positive. At time of analysis, all patients reported no evidence of disease. Of course, further investigation on this appealing treatment, the preoperative approach, are of course needed with larger studies, and maybe investigating a prospective comparison between standard postoperative radiotherapy as compared to preoperative radiotherapy that allowed for translational biology-driven research studies. But this is also the year of the RAP-GEM study, a de-escalation trial of radiotherapy after primary systemic therapy, published by the Dutch group with first name De Wild and last name Professor Lisbeth Bersma. This study tried to evaluate the safety de-escalation local regional radiotherapy in clinical team 1, 2, and 1 patients receiving primary systemic therapy according to a predefined consensus-based study guideline. For those low-risk patients received no chest wall radiotherapy and regional radiotherapy, intermediate risk group YPN1 receive axillary lymph node dissection and local radiotherapy, and the high-risk group of patients, the Epsilon Y and 2 and 3, receive axillary lymph node dissection and local regional radiation therapy, with the hypothesis to obtain a 5-year local regional relapse rate below 4%. These are the group stratification. And these are the main results. They show a 5-year local regional relapse rate on the World Series of 2.2%. That was basically comparable among risk group stratification. 2.1% in low risk, 2.2% in intermediate risk, and 2.3% in high risk. So basically observing these results, a 5 years local regional relapse below 4% was reached, which support the hypothesis that it's safe to de-escalate local regional radiotherapy based on a local regional recurrence risk in selected patients affected by CT1, 2, and 1 disease treated with primary systemic therapy. Of course, further studies are needed because this was not a randomized trial, but a study on a predefined schedule. What we observed in surgery during the last decades was a de-escalation of surgery. The same is not being performed for radiation therapy approach. But please take note of this nice review published in the breast on the de-escalation of axillary treatment over time concerning surgical approaches. And the de-escalation of axillary treatment after primary systemic therapy has been published following the MARI protocol from clinical node-positive patients that follow a response-guide axillary treatment according to this marking axillary lymph node with radioactive iodine seeds MARI protocol. All stage 2-3 patients with pre-primary systemic therapy axillary staging performed using PET-CT and post-primary systemic therapy pathological axillary response measure in the pre-primary systemic therapy largest clinical node positive marked with an iodine seed determined axillary treatment with a 3-year relapse-free interval of 98% and a recurrence risk highest for patients that receive an axillary lymph node dissection. In this case, it's been demonstrated that a de-escalation of axillary treatment according to the Mary protocol basically prevented axillary lymph node dissection in around 80% of patients affected by clinical nodal positive disease. And maybe to be provocative, but I would like to show you the exceptional responders phase 2 trial published on the Lancet Oncology in 2022 by first name Eric Uter. It's a multi-center single-arm phase 2 trial with patients affected by CT1, 2, and 0, and 1 triple-negative HER2 positive tumors after optimal primary systemic therapy that receive standard breast irradiation and a tumor bed boost, avoiding surgery. The primary outcome of this study was the biopsy-confirmed ipsilateral breast tumor recurrence rate, and the vacuum-assisted co-biopsy identified a pathological complete response in 31 patients in this study. The median follow-up was 26.4 months, and no ipsilateral breast tumor recurrence was observed. This was the diagram of the intervention, the biopsy, the omission of breast surgery, and schedule of radiation therapy uses whole breast irradiation, 40 grain 15 fractions of 50 grain 25 fractions with a mandatory boost on the index quadrant with this endpoint. So the conclusions of the authors, of course, is just that the elimination of breast surgery in highly selected patients with an image-guided vacuum-assisted biopsy that determined a pathological complete response following primary systemic therapy is potentially feasible with promising, of course, early results. And of course, prospective clinical trials are absolutely needed in this setting. Again, regional node irradiation in breast cancer patients with residual isolated tumor cell or micrometastatic nodal disease after neoadjuvant chemotherapy. This study was published in CTRO in 2022 by Kim and colleagues in the background that optimal management of residual micrometastasis and ITC in patients with invasive breast cancer that receive primary systemic therapy followed by definitive surgery is still unclear. The study tried to evaluate the regional node irradiation impact on overall survival in patients with clinically node positive invasive breast cancer who received the primary systemic therapy and this residual disease in nodal. It's a method of the study, including almost 2,000 patients from the National Cancer Database. All patients were staged clinical T0, T3, and 1 and 0, and received primary systemic therapy and be stratified in two groups, patients who received regional node irradiation as compared to patients who did not receive regional node irradiation. At a median follow-up of 36.1 months, regional node irradiation seemed not to have a significant effect on overall survival among the patients in the whole series, in the figure A, as well as in the separate subset analysis of patients obtaining a negative nodal status with isolated tumor cell or negative or YPN1 micrometastasis patients only in the figure C. In conclusions, large national population-based analysis of breast cancer patients who receive primary systemic therapy is being presented, with similar overall survival among patients regardless of the ITC or micrometastasis on the nodal status, and no benefit of regional node irradiation in these patients regardless of this kind of two response and nodal status was observed. Of course, the authors concluded that the results of ongoing trial will be absolutely crucial to better define the clear role of regional node irradiation in these patients with residual nodal disease. Again, regional node irradiation and internal mammary nodes. I suggest this study published on the JAMA Oncology by the South Korean group with first name Kim, effective or elective internal mammary node irradiation on disease-free survival in women with node-positive breast cancer. This is a randomized phase 3 trial. These are the methods: pathological nodal positive patients after mastectomy or breast conserving surgery, and axillary lymph node dissection with more than 8 nodes removed. Patients stratified by nodal stage and surgery type that receive 45 to 50 gray in 2 gray refraction and a sequential tumor bed boost with a primary endpoint of 7 years disease-free survival. And the main hypothesis to detect 10% improvement with 80% of statistical power. These are the main results. Median follow-up of 100 months. The baseline characteristics show a median age of 50 years, 40% of patients with medial centrally located tumors, mostly 1 PT1-2, 40% PN1, 36% PN2, 22% PN3 tumors. So most of these patients receive taxane-based chemotherapy and endocrine or anti-HER2 therapy as per indication. So you can see no statistical significant effect was reported by adding irradiation internal mammary node in terms of disease-free survival, breast cancer mortality, distant metastasis-free survival, and overall survival. But at a deeper analysis, the 70-year disease-free survival was statistically favoring the internal mammary node irradiation for medially or centrally located tumors, and the same for the 7 years breast cancer mortality and 7-year distant metastasis-free survival. No statistical significant difference was observed in terms of toxicity, with a trend for higher rates of radiation-related pneumonitis with internally mammary node irradiation, of course, related to the higher dose that the lungs received. In the conclusions and discussion by the authors, no improvement was demonstrated in the overall population with the addition of internal mammary nodes, but we have to take in account the subgroup analysis that was not pre-planned, although a significant benefit was observed for patients with centrally or medially located tumors without reporting a relevant toxicity. Of course, we have to take in account some limitations of this study with the high prevalence of early stage, the effects of modern adjuvant systemic treatments, the use of not modern doses and fractionation, and likely a short follow-up for late cardiac and lung toxicities. Ductal carcinoma in situ. Von Chua and colleagues published on The Lancet this year the results of radiation doses and fractionation schedules for non-low risk ductal carcinoma in situ in the breast, big FIR 307 TROG 0701 randomized multicenter phase 3 trial. This is the background where breast irradiation for ductal carcinoma in situ after breast conserving surgery reduced local recurrence statistically significant in most of the trials, although no randomized trials support the use of the boost to the tumor breast after whole breast irradiation, and the retrospective studies show several variable effects. So no randomized trials support the use of hypofractionation in radiation therapy for ductal carcinoma in situ. So the aim of this study was to investigate whether a tumor bed boost after whole breast irradiation decreased local recurrence, and to analyze if whole breast fractionation sensitivity in patients with no low risk DCIS was effective. These are the methods for patients affected by unilateral no low risk DCIS treated by breast conserving surgery with negative final surgical margins at least one marker of an increased local recurrence risk. So age, presentation, size, multifocality, or tumor grade, the presence of necrosis. Randomization was based on 3 categories. Category A, that receive conventional as compared to hypofractionation for whole breast irradiation and the tumor bed boost versus no boost. Category B, that compare boost versus no boost after conventional fractionation, and category C, that compare boost as compared to no boost after hypofractionation. These are the main results. 5 years free from local recurrence and distant recurrence were significantly lower in the no boost group than in the boost group. No statistically significant difference in between conventional and hypofractionated whole breast irradiation scheduled groups were observed, and the boost group had higher rates of grade 2 or greater breast pain and induration. So a lot of data and important interpretation for these patients. The conclusions of the authors show the results supported the use of a tumor bed boost irradiation after postoperative whole breast irradiation in patients with non-low risk DCIS in order to optimize local control of this disease, but also demonstrated that moderate hypofractionated whole breast irradiation improved the balance of local control, toxicity rates, and socioeconomical burdens of treatment. But there is also more from 2022. The Danish group, first authors Mary Overgaard, published these update results in this study of post-mastectomy radiotherapy in high-risk breast cancer patients given adjuvant systemic therapy, and they reported a 30-year long-term results from the Danish Breast Cancer Cooperative 82BC trial. This was a really pivotal trial for patients treated between 1982 and 1980 by the Danish Breast Cancer Group that conducted this randomized trial in high-risk pre- and postmenopausal breast cancer patients comparing mastectomy and adjuvant systemic therapy alone as compared to same treatment as a postoperative radiation therapy. This 30-year long-term follow-up was really important in order to compare effectiveness, efficacy of the treatment together with the late toxicity of the treatment. These are the study design, more than 3,000 patients randomized to receive postoperative radiotherapy or adjuvant systemic therapy alone. The median follow-up is 34 years. I remind the primary endpoints were local regional recurrence rate and overall mortality rate, and secondary endpoints, distant metastasis, breast cancer mortality, and in radiation-related late morbidity. These are the main cubes of the trial, showing here the 2 primary endpoints, the local regional recurrence and the overall mortality. A statistical significant reduction in the cumulative incidence of local regional tumor failure was observed among the irradiated patients and was present in all subgroups of patients. This was true concerning local regional recurrence, that was statistically significant also in terms of overall mortality. Major prognostic factors in high-risk breast cancer patients were larger tumor size, high-grade tumors, and more than 4 positive nodes. Concerning the secondary outcomes, there was an important and significant effect in favor of post-mastectomy radiotherapy for these high-risk patients concerning distant metastasis, any recurrence of disease, the incidence of contralateral breast cancer, and breast cancer mortality at all. Again, concerning late toxicity, there was no evidence of difference in terms of heart disease, ischemic heart disease mortality, and second primary cancer, non-breast, lung, esophageal, no difference between group of patients. In conclusions, the optimal long-term treatment benefit of high-risk patients treated can only be achieved with the perfect integration with modern radiotherapy and modern systemic therapies. adding post-mastectomy radiation therapy, even in these patients that receive non-modern radiation therapy technique, did not result in long-term excess of cardiotoxic effects, nor in other non-breast cancer-related deaths. So this is really important because the scenario is completely changed currently and improve the effectiveness and reduce the toxicity of modern radiation therapy techniques. And finally, again, from Denmark, Birgit Offersen and colleagues presented the results of partial breast irradiation as compared whole breast irradiation phase 3 trial, the Danish breast cancer group partial breast irradiation trial, published in the JCO at the end of the year. The background, as you know, partial breast irradiation is able to reach good local control, reduce adverse events, and provide more convenient treatment in selected breast cancer patients. The randomized import law trial already showed non-inferiority in terms of local control for partial breast irradiation and reduced dose radiotherapy as compared to whole breast irradiation in terms of 5 years local relapse rate using moderate fractionated radiation therapy. The aim of this trial was to demonstrate the partial breast will neither cause more breast induration than whole breast irradiation at 3 years without compromising local regional recurrence rate. These are the methods. This multi-center randomized phase 3 non-inferiority trial enrolled 880 patients. Most patients were 60 years or older that received breast-conserving surgery for unilateral, unifocal, estrogen receptor positive, HER2 negative, grade 1 and 2 non-lobular breast cancer, PT1 and 0, M0, with final surgical margins more than 2 millimeters, or patients receive 40 gray in 15 fractions. Primary endpoint, breast induration at 5 years of median follow-up. Secondary endpoint, again, telangiectasia, dyspigmentation, evaluation of the scar, edema, and recurrences. These are the main results. There is no point in time during 5 years of observation where induration was in favor of whole breast irradiation, and the overall induration risk during 5-year follow-up assessment was 12% for the whole breast irradiation arm and 8% for the partial breast irradiation arm, statistically significant. Of course, large breast volume irradiated was significantly associated with induration. Therefore, partial breast irradiation reduced the risk of induration in both large and small breasts, with a tendency towards a larger reduction in large breasts. No significant differences in terms of local regional recurrence risk between whole breast irradiation and partial breast irradiation was detected at this time. The 5-year risks were 0.7% for whole breast irradiation as compared to 1.2% for partial breast irradiation. Again, the Danish breast cancer group partial breast irradiation trial provides long-term robust evidence in favor of moderate hypervaccinated external beam partial breast irradiation. In general terms, breast mobility was low for all patients, and cosmetic outcome was favorable and mostly even slightly better after partial breast irradiation. Seems that risk of recurrence was low in general and not influenced by the treated volume in these selected patients. So basically, the Danish breast cancer group recommends, in agreement with the ASTRO-ACROP, ASTRO and ASTRO guidelines, this treatment for selected patients of partial breast should be favored over whole breast irradiation for patients aged more than 50 years old, PT1 and 0 unifocal non-lobular breast cancer, mainly estrogen receptor positive, HER2 negative, grade 1, 2, and final surgical margins at least clear 2 millimeters. I would like to acknowledge my colleagues for the support in this presentation, and would like to thank again the OncoAlert family for this kind invitation, and you, And please feel free to contact me and follow me for any further clarification, waiting for next studies in this amazing, 2023 year for radiation oncology, breast oncology, and clinical oncology at all. Thank you very much.
Dear friends and colleagues, my name is Matteo Lambertini. I'm a medical oncologist from the University of Genova San Martino Hospital in Genova, Italy. And it's really a great pleasure and honor for me to be part of this OncoAlert Colloquium 2022, where I'm going to discuss fertility preservation and breast cancer. In the next 20 minutes, I'm going to focus on the available strategies for fertility preservation in breast cancer patients, focusing on the most important updated data from 2022, and then the second part of the presentation, how to counsel patients that want to have a pregnancy after breast cancer diagnosis, also in light of the important data presented at the San Antonio Breast Cancer Symposium of the positive trial. Before starting, I just wanted to highlight the importance of survivorship issues in cancer care nowadays. Thanks to early detection, more effective treatment, fortunately the prognosis of our patient is significantly improving, meaning that we need to pay attention also to the potential long-term side effects of anti-cancer treatment. And I would say that nowadays survivorship is as important as cancer treatment itself. Regarding young women with breast cancer, when we discuss survivorship issues, this is strongly related to fertility and pregnancy concern, because this is a key priority for our young women with breast cancer. This is a study from the group of Ann Partridge from the Dana-Farber Cancer Institute, showing that at the time of diagnosis, around 50% of newly diagnosed young patients with breast cancer are concerned about the potential loss of fertility as a consequence of the use of anti-cancer treatment. Similar percentage, 40 to 50% of patients, so 1 out of 2 newly diagnosed patients with breast cancer at the time of treatment initiation would still desire to have children following treatment completion, meaning that fertility and pregnancy-related concerns are important for at least half of our newly diagnosed young women with breast cancer. We will discuss fertility preservation mostly, but the toxicity of anti-cancer treatment on the ovaries of our patient is related to a more general concept than just infertility. It's a concept that we define as premature ovarian insufficiency. Premature ovarian insufficiency translates into infertility, so the impossibility to have a pregnancy following treatment completion, but it's a more general concept of early menopause, and it's associated indeed with a lot of other important side effects that can have a major negative impact on the quality of life of our patient: anxiety, depression, sexual dysfunction, and other side effects. Meaning that it's important to discuss fertility preservation, but it's also equally important to discuss ovarian function preservation, so a way to reduce the toxicity of our treatment on the ovaries of our patient. This concept is important because it's key for the patient, but it's also highly relevant from an oncology perspective, because we have several studies in the literature showing that if we do not discuss survivorship issues, and particularly fertility and pregnancy-related concern, patient may be less adherent to treatment, may decide to stop, for example, adjuvant endocrine therapy before the standard duration, or may decide to receive a suboptimal chemotherapy because it's maybe less gonadotoxic, and receiving a suboptimal treatment can translate potentially in worse outcomes. So survivorship issues can translate also in survival issues if they are not properly managed. Moving now to the available strategies for fertility preservation, I will start with the updated ESMO guidelines that clearly highlight the importance and the key of discussing this topic with all patients diagnosed during reproductive age. The key words for the first statement is that this counseling, the oncofertility counseling, should be made as early as possible following a diagnosis and should be made irrespective of type and stage of disease. All patients of reproductive age should be counseled about the potential risk of infertility with the proposed treatment and should be offered the possibility to preserve their fertility and potentially ovarian function. Second important statement is that the treatment we are offering to our patient are associated with a different risk of developing treatment-induced gonotoxicity, but all systemic treatment have a potential risk of gonotoxicity. So all patients should be informed about this risk without over or underestimating this risk, and then it's their choice based on the information that we provide to undergo or not fertility preservation strategy based on this risk of developing premature ovarian insufficiency. So what we have to do as medical oncologists is the kind of first step of the oncofertility counseling, which is discussing the risk of premature ovarian insufficiency. For chemotherapy in the breast cancer setting, is quite straightforward to perform this counseling. We know that age and type of chemotherapy are the most important factors impacting on the risk of developing these side effects. Anthracycline taxane-based chemotherapy regimen in patients above the age of 40 years have a high risk of premature ovarian insufficiency. Same regimen in very young women under the age of 30 years have a low risk, less than 20 or maybe even less than 10%. And then in the middle, patient between 30 and 40 years. The problem we have right now, particularly in the breast cancer field, but also in other diseases, is how to counsel patients that are receiving other treatment than chemotherapy, and particularly targeted treatment options. In breast cancer, we have some preliminary data for anti-HER2 therapies, with some studies reporting on the amenorrhea rate in patients receiving chemotherapy with or without anti-HER2 therapies, particularly trastuzumab, lapatinib, or T-DM1. However, unfortunately, we do not have any data to counsel patients receiving immune therapy, ADCs, PARP inhibitor, or CDK4/6 inhibitor, that are all treatment options that are now available in the early setting or will be probably available very soon. We have two studies in mouse model showing a potential gonotoxicity for the PARP inhibitor olaparib, as well as for immune checkpoint inhibitors. And this is, of course, of concern for our patient, but we definitely need to collect data from clinical trials, but also from real world, from real world, our clinical practice on how to properly counsel patients receiving this treatment on the top or following chemotherapy. Moving now to the available strategies for fertility preservation, this is the second step of the oncofertility counseling that is usually and should be made by the fertility specialist. The first option, the standard procedure, is embryo oocyte cryopreservation. Just wanted to remind that for this option, we need between 2-3 weeks of time for the so-called hormonal control ovarian stimulation, which is a hormonal manipulation that is needed to collect the oocytes following these 10-15 days of stimulation. And then the oocytes can be directly cryopreserved or can be fertilized before cryopreservation. In terms of efficacy data, the pregnancy rate is around 40 to 50%, but this is strongly dependent by the age of the patient at the time of the procedure. The younger the age, the higher the success of this procedure. If the age of the patient is older than 40, 41, 42 years, the success of this procedure is very low, is less than 10%. So at my center, we normally do not refer to cryopreservation procedure, to this cryopreservation procedure, patient older than 40 years. In terms of safety consideration in breast cancer, we have now updated data from 2022 from a meta-analysis showing that the use of these 10-15 days of stimulation is not associated with any detrimental effect on the outcomes of our patient. These data derive mostly from retrospective studies, however, also some recent, quite large studies, all in the same direction of no alarming signal in terms of potential risk of recurrence. If this treatment is being administered to patients at the time of diagnosis, so before initiating chemotherapy, also in the hormone receptor positive subgroup, there is no concern on the safety of this approach. For breast cancer, most of the studies have used letrozole as part of the stimulation protocol, and indeed, letrozole should be added preferably to control ovarian stimulation in breast cancer patients. If we add letrozole, as shown in this meta-analysis, the performance of the stimulation is the same, so there is no detrimental effect on the efficacy of the stimulation, but importantly, there is a significantly lower peak estradiol level during the stimulation, so the hormonal level in the blood of the patient are significantly lower if you include letrozole during these 10-15 days. And this is of importance for breast cancer patients. When there is no time, there is not these 2-3 weeks of time for oocyte embryo preservation, which is usually not that common in breast cancer not to have, but it's more of concern for hematological malignancies or other more aggressive tumors. However, if there is no contraindication or there is no time to oocyte embryo preservation, we can offer this kind of second procedure, which is ovarian tissue cryopreservation. This is a more surgical option. It requires 2 surgeries, one to remove ovarian tissue fragments from both ovaries before starting chemotherapy, and then a second surgery to transplant back the tissue following treatment completion. Based on a very recent meta-analysis, the pregnancy rate is similar to what we have seen for oocyte embryo preservation, around 30 to 40%. Here again is very strongly dependent by the age of the patient at the time of the procedure, and here the age cutoff is lower as compared to oocyte embryo preservation, because this procedure does not appear to be successful in patients older than 36 years at the time of the surgery, of the first surgery. The second important features for the success of this procedure is the expertise of the center in cryopreserving ovarian tissue. Most of the IVF center, all IVF center, I will say, are able to cryopreserve oocyte or embryos. However, ovarian tissue cryopreservation is much more complex, and not all centers have the adequate expertise. So this success rate is observed in patients in centers with a high expertise in this procedure. What the guidelines are suggesting is the possibility to have a so-called hub-and-spoke model, so that the surgery can be done in one hospital and the tissue can be sent to another hospital to be cryopreserved, and between 2 to 4 hours, up to 4 hours away, this is feasible and possible. And at least this is what we do also at my center. We do the surgery and we send the tissue in a city 2 hours away from my city that has I would say, higher expertise in ovarian tissue cryopreservation. An advantage of this procedure, differently from oocyte embryo cryopreservation, is that it does not only preserve fertility, but it also preserves ovarian function, in the sense that when we transplant back the tissue, the patient can resume, in a very high proportion of cases, a premenopausal state, so increase estrogen level, reduce FSH level following transplantation of this tissue. In terms of safety consideration in breast cancer, the first issue is not really important in the breast field. The risk of malignant contamination to the ovaries not been observed in breast cancer. It's more of concern for aggressive hematological malignancies, for ovarian cancer. For breast cancer, the most important concern is the possibility to have an hereditary cancer syndrome associated with the high risk of developing ovarian cancer. So, for example, BRCA carriers. In these cases, ovarian tissue cryopreservation is not the optimal procedure, should be only restricted to patients that cannot receive oocyte embryo cryopreservation and that are very young, so several years before the recommended age of risk-reducing surgery. During the transplantation procedure, we have to pay attention in this setting that this tissue is transplanted back to the ovaries so that we are sure that at the time of the risk-reducing surgery, all ovarian tissue is being removed, due to the high risk of developing ovarian cancer in this setting. Finally, the last option I wanted to highlight is the use of GnRH agonists during chemotherapy. This option is not per se a fertility preservation strategy. This has been studied as an option for ovarian function preservation, meaning to reduce the risk of early menopause. The main mechanism of action is to interrupt FSH production, and so to put the ovaries in a sort of dormant state during chemotherapy so that they are less sensitive to the gonadotoxicity of chemotherapy. In breast cancer, data are now quite clear that this is a standard procedure for ovarian function preservation. It reduces by around 15% the absolute rate of premature ovarian insufficiency, more than 60% reduced risk of developing this side effect. We have also some interesting data in terms of fertility preservation potential, with a doubling in the number of pregnancies for patients that receive GnRH agonists during chemotherapy as compared to those that receive chemotherapy alone. The result is statistically significant. However, again, I wanted to stress that this is not an option that replaces cryopreservation procedure for fertility preservation. This is an option that has been studied for ovarian function preservation. In terms of safety consideration, we are concerned to give hormones during chemotherapy. We know that tamoxifen in preclinical and clinical models is associated with a detrimental effect of chemotherapy, so reduces the efficacy of chemotherapy. However, we don't have any of these data, nor in the preclinical, nor in the clinical setting, that this is the same for GnRH agonists. We have now studies also, randomized trials, also with very large numbers, like the soft and text, showing that there is no impact of concurrent GnRH agonist use during chemotherapy, also among patients with hormone receptor positive breast cancer. In 2022, we published the 12-year follow-up data from the Italian trial that included mostly hormone receptor positive breast cancer patients and that were randomized to receive chemotherapy alone or chemotherapy plus concurrent GnRH agonist. As you can see from the Kaplan-Meier curve that are superimposable, there is no impact of GnRH agonist, no detrimental effect of GnRH agonist use during chemotherapy. Now moving to the topic of pregnancy after breast cancer, I wanted to start by highlighting the fact that still breast cancer survivors have very low likelihood to have a subsequent pregnancy. We can estimate they have around 60% reduced chances to have a future pregnancy as compared to women from a general population of a similar age. One explanation is what we have just seen, the risk of premature ovarian insufficiency and infertility with the use of chemotherapy in the breast cancer field, lack of access to fertility preservation strategies. But the second important reason is that still many of us, many medical oncologists, are concerned that breast cancer survivors should not have a pregnancy because a pregnancy may increase their risk of recurrence. Around 30%, so 1 out of 3 responding physician is concerned that pregnancy is not safe in breast cancer overall, and almost half of them, around 45%, are concerned that pregnancy is not safe in BRCA carriers. However, the available data do not support these concerns, so these are mostly based on our misconception, on our biological knowledge or misconception, potentially, because the available data are strongly suggesting that following proper treatment and follow-up for breast cancer, pregnancy should not be contraindicated. There is no detrimental effect for pregnancy after breast cancer. Actually, there is a tendency for better outcomes in those patients with the pregnancy following treatment completion, in both disease-free survival and overall survival. Several studies have been conducted, mostly retrospective, but some recent large studies, well conducted also from a statistical perspective, to correct for the potential healthy mother effect. And still all the same conclusion that pregnancy is not detrimental following proper treatment and follow-up for breast cancer. We have reassuring data also for patients with hormone receptor positive breast cancer, so the most hormonally driven form of tumor. 10-year follow-up data from these studies clearly showing no difference between patients with or without a pregnancy, and the potential better outcomes for those patients with a pregnancy in the ER-negative cohort. We have also same data in BRCA carriers, study that we included more than 1,000 BRCA breast cancer patients, around 200 at the pregnancy following treatment completion. Again, no difference in survival outcomes, a tendency for better outcomes in those patients with a subsequent pregnancy. Coming now to the San Antonio Breast Cancer Symposium, finally, we had a very important presentation of the positive trial by Ann Partridge. This is a very important study because it wanted to address a clinical question that we have every day in our clinical practice. What I've shown so far is that pregnancy is safe following proper treatment and follow-up. And for patients with hormone receptor positive breast cancer, a proper treatment is at least 5 years of adjuvant endocrine therapy. This study wanted to investigate the safety of stopping adjuvant endocrine therapy for around 2 years in those patients aged less than 42 years with a strong pregnancy desire that completed at least between 18 months up to 30 months of adjuvant endocrine therapy. This trial included more than 500 patients. I wanted to highlight that most of these patients had a stage 1 and stage 2 disease. Most of them received tamoxifen alone as adjuvant endocrine therapy, and 60% of them received prior chemotherapy. The follow-up is still a bit short. It's a bit more than 40 months, so we need to wait for a longer follow-up. But based on the data that were presented in San Antonio, we can say that this short temporary interruption of endocrine therapy is safe to allow women to have a pregnancy instead of waiting 5 years of adjuvant endocrine therapy. Comparing the relapse rate with a similar population of premenopausal patients with breast cancer, including the SOFTENTEX trial, we see that there is no difference in the patient included in the positive trial. So this should be considered a safe procedure. However, based on this data, we'll still be cautioned to counsel patients that have a very high risk of recurrence, or those patients that are very young and may wait a bit longer to try to have a pregnancy. For the high-risk patient population, especially if they are very young, I will definitely try to counsel them to keep on the first 5 years of adjuvant endocrine therapy before having a pregnancy. But based on this data, for sure, a patient very close to the age of 40 with a stage 1 hormone receptor positive breast cancer, I will not have any concern to counsel the patient about the safety of this approach. Moving now to the safety from the baby side, what we know is that there is no increase of malformation in these pregnancies. However, there is an increased risk of some pregnancy complication, like cesarean section, low birth weight, preterm birth, and small for gestational age, as compared to the general population. And what is known is that the risk of this complication is higher for patients that have a pregnancy very close to chemotherapy completion. Those patients that have a pregnancy within 1 year following chemotherapy completion have an increased risk of this complication. Those patients with a pregnancy that occur in more than 1 year following chemotherapy completion apparently have no difference in pregnancy complication as compared to healthy women from the general population. In any case, what we recommend is a closer monitoring of these pregnancies, considering these pregnancies as kind of high-risk pregnancies, so to follow them more closely as compared to what we do in the healthy general population. Final point is the timing to have a pregnancy following treatment completion. In my case, this is based on the age of the patient. So the younger the patient, the more potentially she could wait, and then the risk of recurrence. The higher the risk, the longer I will definitely wait before attempting a pregnancy. Besides age and risk of recurrence, we have to consider that we need to have a specific washout period that is different according to the type of treatment that the patient has received to have a pregnancy in a safe environment. For chemotherapy, the washout period is around 12 months. As we have just seen, it's better to wait at least 12 months to avoid some pregnancy complications. For monoclonal antibodies like anti-HER2 agent, trastuzumab, pertuzumab is around 7 months. For tamoxifen is around 3 months, as done also in the positive trial. In some countries, this has been moved to 6 or 9 months, but I would say that 3 months is a safe timeline. Then we have a question mark for all the treatment that are already available or that are potentially moving to the early setting. This is just a proposal based on the half-life to wait at least 1 month for olaparib, to wait 4 months for pembrolizumab, and around 3 months for abemaciclib. In conclusion, how to perform an oncofertility counseling in young women with breast cancer. First point is what we have to do as medical oncologists is discuss the risk of premature ovarian insufficiency with the use of anti-cancer treatment. Then those patients interested in fertility preservation should be sent to fertility specialists as early as possible after diagnosis. And then the fertility specialist will discuss the available option for fertility preservation. In those patients that have at least 2 weeks of time, oocyte embryo cryopreservation is the standard option in the first procedure to be discussed. Ovarian tissue cryopreservation should be offered to patients with contraindication to oocyte embryo cryopreservation, or in those patients that have no time before initiating treatment. Following cryopreservation procedure, GnRH agonist during chemotherapy can be also used. In those patients not interested in fertility preservation, we don't need to send them to fertility specialists, but we have to counsel them about the possibility to preserve ovarian function to reduce the risk of early menopause with the use of GnRH agonists during chemotherapy. Final point, to properly manage young women with breast cancer and fertility and pregnancy-related issues, we need to have a close collaboration, a close network with fertility specialists. We have to build a so-called oncofertility unit. This oncofertility unit is key to refer patients in a timely manner to fertility preservation option, but it's not only the access to this option that is relevant in terms of building this network, because this network, and I can say that it's very helpful in my clinical practice, is also very useful during the follow-up of our patient to discuss other gynecological related issues that our breast cancer patient may have. One is contraception, for example. One is the management of gynecological side effects, sexual dysfunction, hot flashes, menopause-related symptoms.
Hi, I'm Cheung, a breast surgeon from the University of Nottingham, the United Kingdom, and also part of the International Society of Geriatric Oncology, SWOG. I'm going to talk to you about how to decide between surgery and primary endocrine therapy for early operable breast cancer. I want to cover 3 areas. The decision can be based on the assessments of the tumor and also of the person. And I want to cover briefly about the cost effectiveness between these treatment strategies. And finally, I just wanted to close by sharing with you the latest recommendations from EUSOMA, European Society of Breast Cancer Specialists, and also SWOG on this very topic. Assessments of the tumor and the person. Breast cancer is no longer a single disease, it's heterogeneous. As we all know by now, there are many subtypes and a lot of genes involved. As a result, when we are considering primary endocrine therapy, we should no longer consider this option at all for cancer which is estrogen receptor negative. But even with ER-positive breast cancers, there are heterogeneity factors to consider as well. This is part of the work from my group. If you compare surgery versus primary endocrine therapy by looking at the degree of ER positivity using immunohistochemistry, which measures something called H or histochemical score. The values are between 0, which is ER negative, and also 300, which is the maximum H score, meaning that the cancer is extremely ER rich. If we look at patients who were treated by surgery versus primary endocrine therapy in those with an H score of less than 250, what we found from a consecutive prospective cohort was that surgery actually produced much better breast cancer specific survival. However, when we just include patients who got an H score of more than 250, that means very, very ER rich, then surgery and primary endocrine therapy produced equivalent breast cancer specific survival. Now, this is looking at breast cancer specific survival alone, which can be viewed as a surrogate of the biology of the tumor, because we do not consider overall survival, which takes into account of competing causes of death, which I will come on to later on. But even from biology alone, we can see that it is not just simply ER positivity, but the degree of ER positivity. For now, this is the only thing we can base on. My research, which is ongoing, covers other biological factors that we try to take into account too. There have been a few systematic reviews in the literature looking at this subject. The first one published many years ago, looking at surgery versus primary endocrine therapy from 7 randomized controlled trials. They were old trials, not up to modern standard. And in Nottingham, we did take part in 2 of those. Recently, with my collaborators from Singapore, we have carried out the 3rd systematic review of the literature with meta-analysis of the data based on statistical modeling of all these studies, including prospective and retrospective studies. This paper is currently in press with British Journal of Surgery. What we found here was when we looked at overall survival and surgery shows significantly much better outcome when compared to primary endocrine therapy. When we look at breast cancer specific survival, there is no statistically significant difference between the two with meta-analysis of all the data available. So how about the patient? If we look at the tumor, just now looking at ER positivity, let's look at the patient. As we all know, an older woman could be a very fit person, but could also be a very frail person. And that's why we are considering doing a lot of geriatric assessments for these people, which is being advocated in the field of geriatric oncology. Surgery is modern, and we seldom think about post-surgical mortality or immediate morbidity. And because of the modern surgical technique and anesthesia, it is a very safe procedure. So therefore, we no longer should think about whether someone is fit for an operation or not in order for us to decide whether the patient should be put on primary endocrine therapy rather than surgery. This is a very rare consideration. However, what is more important is to consider how likely that the patient might survive given their other comorbidities. As we now know that the number of comorbidities does have an impact on survival or on life expectancy of anybody, even without breast cancer. So therefore, for people who have got a significant number of comorbidities, their life expectancy may be limited. Then the question will be, can we control the cancer with primary endocrine therapy without surgery for their remaining time of life? As part of my work, we also look at different kinds of endocrine therapy when we compare using anastrozole, which is now one of the third-generation aromatase inhibitors widely used in breast cancer, with the prototype endocrine therapy tamoxifen, which used to be used more often as primary endocrine therapy in the past. When we compare the two in our prospective series, which is probably one of the biggest in the world, what we found was the time to progression on first-line endocrine therapy was 5 years median, as compared to 4 years median with anastrozole when compared to tamoxifen. In other words, if we put someone on aromatase inhibitors instead of doing surgery, we got a median time to progression of 5 years. So if someone has a median life expectancy of 5 years, primary endocrine therapy alone may be sufficient to control the cancer in their lifetime. So how about cost effectiveness? We have done some work with our collaborators at the University of Manchester looking at health economics. You can read the full papers yourself in your spare time, but briefly, when we look at surgery, surgery has been found to be a cost-effective strategy for older women aged 70 or above with estrogen receptor positive early stage breast cancer who are fit for surgery or pre-frail, which means they are not that frail. They are pretty much fit. So therefore, their life expectancy is expected to be quite long. So in that group, surgery is a cost-effective strategy. How about primary endocrine therapy? So if for patients, still older patients at about the age of 70, but if their frailty score was high, so they are more frail, and so therefore primary endocrine therapy appears to be a potentially cost-effective strategy. So that goes back to the same concept that within the tumor assessment, ER-positive breast cancer, if someone is frail, more likely to die from competing causes of death, primary endocrine therapy becomes increasingly cost-effective. similar findings have been found by statistical modeling in the UK-wide age gap study, which is one of the biggest studies reported in the world to date. And in using prospectively collected data in consenting patients for women with breast cancer diagnosed at the age of 70 or above. Several thousands of patients took part in this study. So in this study, I'm part of the trial management group as well. We looked at also cost effectiveness. So briefly, most women who were 70 years of age or above at diagnosis, surgery plus adjuvant endocrine therapy was shown to be clinically effective as well as cost effective. However, cost effectiveness of surgery decreases with increasing age and increased number of comorbidities. And for women 90 years of age or above with multiple comorbidities, surgery seems to produce little cost benefit and a negative impact on quality of life. So similar message confirmed by a much bigger study. Finally, I just want to close by sharing with you the most up-to-date EUSOMA and SWOG recommendations on this very topic. So as one of the authors, alongside many colleagues in EUSOMA and SWOG, we have published the updated recommendations regarding the management of older patients with breast cancer. So this is not just about surgery or primary endocrine therapy, but about everything in relation to the management of older patients with breast cancer. So I encourage you to read the article, the whole article published in Lancet Oncology exactly 2 years ago. But just to show you the section regarding surgery and primary endocrine therapy. So the recommendation was that surgery remains the choice of primary treatment in the majority of older patients with early breast cancer. But primary endocrine therapy may be considered as an alternative in selected patients with a strongly ER-positive tumor. So taking into account the tumor assessment and also short life expectancy, no more than 5 years. Again, taking into account of the person. Adverse events of endocrine therapy should be taken into account in this decision. So thank you very much.
Dear colleagues, thank you very much for joining us today for this day 1, and please join us tomorrow when we'll be covering 2022 in FDA approvals by Dr. Morgan, GU Oncology with Dr. Schwery, Agarwal, Grievous, McBride, and Mr. Lewis, and a special session on immuno-oncology and targeted therapies by Drs. Hannon, Sabaya, and Scote from our partners at Astro and Mask. We look forward to seeing you tomorrow, and thank you for your attention. Until then, thank you for sharing this colloquium, and thank you for being OncoAlert.